Dr. Manish Pruthi, sir, have you joined?
Hi Sudhir, how are you?
Hello, Dr. John, sir. Jagandeep here.
Steve, how are you?
Good, sir. I'm good.
Good.
So I think so, sir. We will start at dot 6 because.
Yeah, sure. I'm ready anytime.
First.
Yeah, I think we should. If we don't start on time, we'll never keep to time.
Exactly.
कैमरा ऑफ है
कनेक्ट तो है
नहीं
अब देखो
वैसे ही नहीं आ रही चलो इसके थ्रू ना आए वैसे तो आनी चाहिए
इसमें क्यों नहीं आ रही
Hi, good evening, Jagandeep.
Good evening, sir.
How are you?
Good, sir. Can you see my video, sir?
I can see your video. Yeah. Hi, Manish.
Hi, sir. Hi, Jagan. How are you?
Hi, sir. Good, sir. Good. Nice, sir.
Nice to see you. Great. Good program.
I'm so, sir.
Yeah. I am still not out of IMSOS only.
The hangover of IMSOS, sir.
Yeah.
Right.
Hi, Dr. John.
How are you? Hi Sudhir.
हेलो गुड इवनिंग सर
Hi, Jagan.
Good evening, sir.
Hi.
Hi Dr.
Hi, Dr.
Jitendra.
Jinder.
Hi everybody. Yeah.
Hi, Dr. John. Yeah.
It's already 6 o'clock, isn't it? So what time do you
Yeah.
start, Jagandeep?
It's 6, not 6. Sir. I think we can start, sir.
Anytime.
Right. So, warm greetings on behalf of the Paras family. And I, Dr. Jagandeep Singh, consultant orthopedic oncosurgery at Paras Hospital, welcome you all to this first virtual Paras Cancer Conclave 2021. So, we'll be starting the session on bone tumors and sarcomas. I would like to invite the chairpersons, introduce you to the chairpersons for this session. So, the chairpersons for this session are Dr. Tajinder Kataria. She is chairperson, Division of Radiation Oncology at Medanta Cancer Institute, Medicity, Gurgaon. She will be joining us at around 7 p.m. She had some urgent work. Dr. J.K. Singh, he is Director of Oncology at Paras HMRI Hospital, Patna. I welcome you, sir. And Dr. Ashish Golia, he is Professor of Orthopedic Oncology at Department of Surgical Oncology, Tata Memorial Hospital, Mumbai. So Dr. Golia will not be able to join us due to some unavoidable circumstances. So I would invite Dr. J.K. Singh to kindly introduce the first speaker for the session, and we can start, sir.
It's my friends, it's my great pleasure to be a part of this prestigious webinar, which is focused on the sarcoma and bony tumors. I think we are dealing in this particular session about the various types of day-to-day problem, which is a practical problem we are facing every day. And I'm sure the learned speakers will discuss and they will address the issues related to our these problems. So without wasting the time, I will call upon Dr. Manish Purti. He is from Delhi, very renowned oncologist, and his topic is approach to a case of bony swelling and bony biopsy. Very important. So, Dr. Manish Purti, please.
Yeah. Thank you very much, Dr. Jitendra, and thank you very much, Dr. Jagan, for inviting me here. So I'll start sharing my screen. Just let me know when it is visible. Is it visible?
Yeah, it's visible.
Yes, sir, visible.
Yeah, just a second. So basically, to cover an approach to a bony swelling and biopsy in 7 minutes is a very difficult task. So I think that time is too short, but I'll try to highlight the most important things here. So the most important thing in an approach will be a brief history and examination, which all of us should be aware of to understand the salient points and for differentials. To understand the role of radiology in evaluating the bone tumors. And finally, I'll be touching on biopsy. Basically, I'll be showing a small video of biopsy for us to understand the technique of biopsy. So if you ask me how to approach a bony swelling, I think the approach is different if the patient age is less than 40 years as compared to a patient who is more than 40 years, as compared to a patient in which we incidentally detect a lesion for some other in some other investigation done for some other disease. So basically, when we are dealing with a painful bone neoplasm in less than 40 years, we are more or less dealing with a primary bone neoplasm as compared to more than 40 years in which the metastasis is more common. So for today's talk, I'll be focusing mainly on the patients who are less than 40 years. So let's start straight away with a case. This is a 14-year-old male presents with a suspected bony swelling in the lower end of femur. So what we do, we first take the history. History, we ask for the site, the pain, the number, any history of trauma, the progress, family history, and the past history. These are centered history points that we ask. So basically, but my question is, does these points help us in diagnosis? If you ask me, yes, a little bit, because a bone tumor, as we know, are most commonly seen around the joints. Sometimes they are multiple, but the conditions are very limited. And in axial skeleton, we know that the Ewing sarcoma or chordomas are much more common in the spine. As far as the history of trauma is concerned, almost all malignant tumors will give some history of trauma. So is it significant? Sometimes it will help in clinching the diagnosis, but not always. Like this patient, a 22-year-old male, had a pain in the paraspinal region following a trauma. So it was reported a neoplasm in MRI. We took a detailed history. There was no constitutional symptoms. The pain was persistent, but it was improving. We did a CT and we showed classical myositis ossificans. So in certain cases, a history of trauma can actually rule out an aggressive looking neoplasm from a malignant to it can convert into a benign diagnosis like a myositis. As far as the duration is concerned, we all know the rule: rapid growth, short duration, more chances to be an aggressive lesion or a malignant lesion. As far as the pain is concerned, if it is persistent or a night pain, so these are the most important pain which will happen in a bony swellings. But in certain scenarios like osteoidostoma, this will be a typical night pain relieved by NSAIDs. But one thing that the pain definitely tells us is that the lesion is symptomatic and we need to do something about it. We cannot ignore a painful bone neoplasm and can send the patient back home if the patient presents with the pain. So what about the family history? We'll be discussing in I think an hour later about Lee-Fromani syndrome, how the bone tumors or the soft tissue sarcomas appear in Lee-Fromani syndrome. This is one of the genetic syndrome in which the bone tumors are like were part of a sarcoma, are part of the LFS group of syndromes. Other familial syndromes could be an hereditary exostosis or a retinoblastoma syndrome. So once we finish the history, we know, okay, this patient looks like an aggressive short history, aggressive neoplasm. in the history. Then we go to the examination. We definitely examine the chest and the lymph nodes in the general physical, and we do a good examination of the local site. And once we are done with, we make a general framework, like now we are dealing with a suspected primary malignant neoplasm of the lower end of a femur, as was seen in this case. So once we have little bit idea, like we're dealing with a primary malignant neoplasm, then we have to actually have some differentials in mind. At this age, with this kind of a diagnosis, we are thinking about these three most common histologies. But then what to do next? Should we straight away go to a biopsy? Because now we are thinking of a malignant bone neoplasm. The answer is no. Because the most important next investigation will be a plain radiograph. How the plain radiographs help is, so we see basically 4 points in the radiograph. First is where is the lesion. Second is the lesion and what is the lesion doing to the bone. Third is what is the bone response. And fourth is anything suggestive of matrix. So allow me to read this radiograph. This is a lytic destructive lesion in the metaphysia epiphyseal lesion of the lower end of a femur. So this covers where is the lesion. What is the lesion doing to the bone? It is causing a permeative destruction, cortical destruction, large soft tissue mass. What is the bone response? It is because the bone is making a periosteal reaction. And what is anything suggestive of matrix? Yes, it was a huge osteoid matrix. So aggressive periosteal reaction and a permeative destruction with the osteoid matrix, we are more or less sure that we are dealing with osteosarcoma. So now can we jump for a biopsy? The answer still remains no, because we still need to do MRI. And how the MRI helps us is in understanding the extent of lesion, which could be intraosseous, as well as the soft tissue extent, to the joint involvement, neurovascular mental involvement, and very importantly, planning the biopsy site, because many of the time the tumor can be cystic or necrotic. So MRI can help in targeting a biopsy site. And sometimes it helps in identifying the specific tumor histologies like cartilaginous tumors or in telangiectatic osteosarcoma. So once we do this, now we are more or less sure that we are dealing with an osteosarcoma. So the next logical steps goes a biopsy. So the indications of biopsies are aggressive or malignant appearing lesion, which is either in the bone or soft tissue, or in an unclear diagnosis in a symptomatic patient, or in a special situation when there is a solitary lesion in a patient with a known history of carcinoma. When we should do biopsy, this is a very important line that all of us should remember. It should be regarded as a final diagnostic procedure, not mere as a shortcut to diagnosis. It was given by Mr. Norman Jaffe, who was a very popular medical oncologist. So basically, investigations are radiographs and MRI. I'll just show you a small video how we do a biopsy. This was a patient who was a 16-year-old male, had a swelling in the calf. So this was primarily a soft tissue tumor in the MRI. As you can see, there's a huge lesion. You can see some white area in the lesion which are more cystic, where we should not be targeting that area. This is the equipment that we require in the OPD to do a biopsy. Basically, we do a true cut biopsy, which is done by a biopsy gun. This is how we load our biopsy gun. And once our biopsy gun is ready, you can see how it cuts the core. So it has a small slot there, and once we pull it, then it will cut the core in the tumor. You can see how we fire it, and then it just goes inside the tumor, and we can actually collect the core in the slot of the biopsy gun. I'll just, if you have 10 more seconds, I'll show you how we are cutting the core.
No problem, so you can continue.
Yeah. So then we pain drape the patient in the standard way. Once we are done, we give a local anesthesia. And basically, most important thing is the surgeon who is going to do the final procedure is doing the biopsy, because he only knows the proposed incision, or the team who is managing the sarcoma should be doing the biopsy, because we should always know the proposed incision before doing a biopsy. A small amount of local anesthesia is given in the skin and the subcutaneous tissue. Yeah. So once this is done, we give a stab incision. and now use our gun to take the cores from the tumor. And basically we take cores from multiple directions, but through the same entry point. That is a very important point, because most of the tumors are heterogeneous or variegated. So we have to take cores from a different direction. So we have to get a exact representation of the tumor. And this is how we'll get the core. And we usually take 5 to 6 cores in a case of bone or soft tissue swellings. That's it. Thank you very much from my side. And if there are any queries, I'm happy to answer.
Thank you, Dr. Manish, for making a basic topic quite
Thank you.
interesting and precise. Sir, we will be taking the questions at the end of the session, if time permits.
No worries.
So I will request the chairperson to introduce the second speaker. And I would like to tell that we have received around 8,000 registrations for this Paras conclave, and I think so a lot of general orthopedic surgeons as well as oncologists will be benefited by this conclave. So, Dr. J.K. Singh, you can introduce the second speaker for the session, sir.
Yeah. Thank you, Dr. Manish, for excellent deliberation. And you have explained everything in a very nice way. Right. Thank you very much. And now we'll move on to another topic. That is the management of cystic lesion of bone by surgical or non-surgical methods. The speaker is Dr. Srinath Gupta. He's from Hyderabad. He's a very renowned orthopedic oncologist and orthopedist in Secunderabad, Hyderabad, a Krishna Institute of Medical Science in Secunderabad. So with this few short, I think, introduction, I will request Srinath Gupta to start his presentation, please.
Thanks a lot, sir. I would like to thank the organizers, Dr. Jagandeep, Sudhir sir, everyone for giving me this opportunity. I will be talking about cystic bone lesions and why they are more important to know. They are tumors of undefined neoplastic in nature, and they are very rare and have overlapping clinical radiological picture. And that is why we have to be aware of what we are dealing with before we finally start intervening. There are two categories, primary bone cysts and secondary bone cysts. These are the most commonly seen primary bone cysts, and these are the most commonly seen secondary bone cysts. Secondary bone cysts are arising because of underlying other conditions within the body. Can be fibrous dysplasia, Brown's tumor, telangiectatic osteosarcoma, or eosinophilic granuloma. So I will be, in the next few slides, I'll be talking about the most common bone cysts that we encounter, and talking about the clinical presentation, radiological presentation. But the final diagnosis can only be after the histologic confirmation as described by Manish Pati sir. So the first we are discussing about simple bone cysts, the benign fluid-filled cavities which expand and cause thinning of the cortex, most commonly seen in the first and second decade, metaphyseal region, common sites are proximal humerus and proximal femur. Radiology, they have central well-defined lytic lesions. If they have a pathological fracture, you can have a fallen fragment sign. MRI will show T2 hyperintense lesion and post-contrast peripheral rim enhancement. And treatment can be either conservative, if it's in a non-weight bearing or asymptomatic sites, or you can also do a percutaneous therapy like a steroid injection or a bone marrow or a DBM injection. Curettage or bone grafting or stabilization with implants can be done for symptomatic cases or cases where there is impending fracture. So we have this meta-analysis which was published, and they've analyzed 32 studies and said conservative treatment is an option for incidentally detected lesions, or surgical intervention should be done in cases where there is impending fracture, like in this case, where synthetic bone graft was used and excellent remodeling over a period of 3 years. So the treatment depends on the active phase or the latent phase. Latent phase can be observed and active phase needs more aggressive management. Next, we are going to talk about the aneurysmal bone cysts. They are benign, locally aggressive lesions, most commonly seen in the first and second decade. Site is a metaphyseal region, and the most common location is proximal humerus. Radiology-wise, we have multiloculated eccentric expansion lesions. MRI will show fluid levels and absence of solid component. It's very essential to rule out any solid component, because if there is solid component, that means we are dealing with secondary ABCs and the management will be different. So if you're doing a biopsy, you have to take biopsy samples from the solid component. So treatment-wise, they are traditionally it was curettage and bone grafting, which was more invasive, but now it's changed to percutaneous management, which is minimally invasive. Thanks to these papers from AIMS and Tata Memorial Hospital, which have said that more than 80-85% of the lesions can be treated with sclerotherapy, and the magic drug being polydeucanol. It's a sclerosant. This is a short video presentation I'll be showing wherein we do how to do a sclerotherapy. And this is the Jamshedi needle is what is needed, and then you do a stab incision, put in the needle, aspirate the content, and once you aspirate the content, confirm the location on the C-arm, and then you do a rigorous curopsy. You can see the curopsy wherein you are scraping all the walls, and once you do a scraping of all the walls, then you inject the dye. Once you inject the dye, you have to check if there's any leakage. If there is no leakage, then we can go ahead and inject the sclerosant. And once the sclerosant injection, just suturing of the stab incision is needed and nothing else. And with this simple minimal invasive procedure, we get beautiful results. You can see this is the proximal fibula, which was treated the same way. And also in cases such as in pelvis, you have excellent response. So you do a radiological assessment every 6 to 8 weeks. And the end point of the treatment is when the patient will have a resolution of symptoms and there is no further growth and there is increase in cortical thickness. So like I said, a J needle procedure is more than enough instead of going ahead with a surgical procedure. Next, we're going to talk about fibrous dysplasias. Fibrous dysplasia is a disorder where normal bone marrow is replaced with fibrous tissue. This causes weakening of the bone and deformities within the bone. It is a radiology-wise, there are well-defined expansional lesions, and then there are lytic lesions with ground glass matrix, and endostal scalloping may or may not be present. And the bone, if left untreated, can go into deformities like the shepherd deformity in the proximal femur. The types are monoosteotic, polyosteotic types, and also can be part of syndromes like in endocrinopathies. Treatment is, again, if asymptomatic or instantly detected, can be observed. Medical management like zoledronic acid every 6 monthly, along with calcium and vitamin D3 can be given for symptomatic cases. And surgical management like curettage and stabilization is needed for cases where there is impending fracture or in deformity correction. So identifying it early and administering zoledronic acid will strengthen most of the bones and prevent aggressive therapy. Next, I'm going to talk about LCH or eosinophilic granulomas, most commonly seen in the exoskeleton. Radiology-wise, they're more aggressive looking. They have a wide zone of transition, but on MRI, they have perilesional edema in T2 post-contrast, which is the most classic sign, and then it is significant in diagnosing LCH. It can be single system or multi-system. And so to identify if they are single or multi-system, skeletal staging is very essential. So treatment depends if it's unifocal or multifocal. Unifocal, usually observation, and they can resolve over a period of some time. And curettage and radiotherapy in symptomatic lesions is needed. Whereas multifocal, more aggressive management, extensive management needed, such as steroids and chemotherapy, and radiotherapy or surgical management symptomatic lesions. Next, we talk about Brown's tumor. Brown's tumor, radiology-wise, very much similar to giant cell tumor, and also histology, it is similar to giant cell tumor. So it is very essential to identify what we are dealing with. And for all giant cell tumors, it is very essential to do a serum calcium phosphorus parathormone. So once you identify if it's a giant cell tumor or a Brown's tumor, the treatment will be defined. So if it's a brown tumor, the correction of the cause of hyperparathyroidism is very much essential, along with vitamin D and calcium. The surgical management is limited for cases where there is impending fracture. So it's very essential to differentiate GCTs from Brown's tumor. I have last few slides and finish off with a case scenario. It's a 15-year-old girl, pain and swelling in the proximal humerus. You can see there's a lytic lesion in the proximal humerus with fluid levels in the seen on the MRI. So like Manish Pruthi sir explained, for all cases, the next step will be to do a biopsy. We went ahead, did a biopsy. If you look at the MRI, you probably can think it can be an ABC or any locally aggressive lesion, proximal humerus. But then biopsy showed us it's a telangiectatic osteosarcoma. So it is very essential that you do a biopsy, determine what we are dealing with, and then plan further. So telangiectatic osteosarcoma is a secondary type of cystic bone lesion that we're dealing with. So if you can go back to the X-ray, you see a wide zone of transition. There's a break in the cortex, and that's how radiology is significant. And then telangiectatic osteosarcoma treatment will be like any other conventional variant of osteosarcoma, where we give chemotherapy, surgery, and adjuvant chemotherapy post-surgery. So biopsy and reporting by an experienced bone sarcoma pathologist is extremely important. With this, I would like to end my presentation, and I would like to thank the organizers again.
Thank you, Dr. Srinath, for an informative talk and
Thank you,
sticking
Dr.
almost on
Srinath.
time. So I'll be starting with the third talk for the session. Dr. J.K. Singh,
Yeah.
with your permission, I can start with the third talk for the
Yes.
session.
Yeah. Please, Jagandeep, please. I think short introduction. Jagandeep is orthopedic oncosurgeon and in the joint replacement surgery, Paras Hospital, Panchkula. Very renowned person. Please start, Jagandeep.
Yes, I can't share my screen. Okay.
Sir, there is a share screen button.
Okay, now I get it. So my screen is visible now.
Yes.
I'll be talking about percutaneous radiofrequency ablation for bone tumors. It is quite an overlapping topic between the interventional radiologists and the orthopedic oncosurgeons. But in our institute, it is usually the orthopedic oncosurgery team which is managing them. So radiofrequency ablation is a form of thermal ablation for killing tumor cells. It is the treatment of choice for benign bone tumors such as osteoid osteoma and other benign conditions such as chondroblastoma, osteoblastoma, giant cell tumors in certain situations, as well as in a palliative setting for metastatic and myeloma lesions. So doing it under image guidance, especially CT, is critical to success, and it is preferred over other imaging modalities such as fluoroscopy or MRI because it provides faster imaging acquisition and has a better anatomic resolution of the bone tissue. Can be done in a percutaneous method most of the times. Case selection is crucial. So case in point is the 6-year-old boy who presented to us with pain in the hip region for the past 3 months. The child had a typical history of pain at night, which was relieved on NSAIDs. So usually a CT is a clincher for diagnosis as far as osteoid osteoma is concerned. So the child had an X-ray, MRI done from outside, we got a CT done. So we can see a typical nidus in the inferior part of the femoral neck region, in the calcar region. And this is the basic instrumentation which is required for doing a radiofrequency ablation. We need grounding pads, K-wires, we need a drill, Jamshedi needles, RF probe, and of course a RF generator. So this is the setup. We do it under general anesthesia or laryngeal mask airway in the CT scan suite itself. Localization of the lesion with the CT scan is very important for planning our approach, access and relationship to the neurovascular bundle. So once that is done, skin marking and standard plating and draping is done. We introduce a K-wire. Either it can be introduced freehand, checked under CT scan, or if we are entering through the contralateral cortex, as was in this case, we can make it enter through a drill. Once we have reached up to the lesion, a Jamshedi needle, the cannula of the Jamshedi needle, usually an 8-gauge one, is cannulated over the K-wire, and then we enter into the lesion. In case, because of extensive perilesional sclerosis, we are not able to enter into the lesion, we can use a drill to enter the lesion. We take biopsy from there. And once we are done with that, then we do the parking of the radiofrequency ablation probe into the nidus of the lesion. So this is a very critical step. Ensuring the intranidal position of the RF probe is very important for a successful radiofrequency ablation for osteoid osteoma. As we can see in the second figure, that the RF probe has been positioned into the nidus. Then retracting the cannula of the Jamshedi needle is another critical step because the cannula can transmit heat into the surrounding tissue. So we have to retract it at least by 5 to 6 centimeters in order to avoid heat transmission to the surrounding tissue. So once that is done, we have ensured the intranidal position. Standard ablation is carried out for approximately 8 to 10 minutes. We have to reach a temperature of around 90 degrees Celsius, which is maintained for about 4 to 5 minutes. So once the ablation is over, we again do a CT scan to reconfirm the intranidal position of the probe before switching it off. So the average duration of the procedure after the anesthesia is around 30 to 40 minutes. Analgesics are continued for around 24 to 48 hours. In case of older children, it can be done as a daycare procedure. Walking is allowed from the next day and running after 6 weeks. So another case, osteoid osteoma in a similar location, this time in a 7-year-old boy. We can see in the CT images that we have entered into the lesion, RF probe into the nidus, carry out the RF ablation, and this is at 1 month. 1 month, the child was actually not walking and was walking with a limp before the procedure, and at 1 month, the child is totally pain-free and able to carry out all his routine activities. Another case scenario is this time in a rather rarer location in the supraacetabular region, although it has been reported osteoid osteoma in the pelvis, and supraacetabular region is the most common site. So we again plan the RFA in the standard protocol, and so this is the function at the end of 1 month. Histology confirmed it to be an osteoid osteoma. So in this case, we can see this is a rather rarer location for an osteoid osteoma. The intramedullary, most of the times either it is intracortical or subperiosteal. The patient actually had 2 MRIs done from outside, and the radiologists were not very clear that whether it was a Broddy's abscess or an osteoid osteoma. We can proceed with a biopsy first in these cases and do the definitive procedure later on. Another way is we can do a bone scan, which is usually a clincher if we have to differentiate infection from osteoid osteoma. A bone scan on an osteoid osteoma will show a hotter spot within the hot area, whereas a Broddy's abscess will show a central reduced uptake area of purulent material and not a hotter spot within a hot spot. So we did the RF ablation, and this is the function at 1 month. So some technical inputs as far as percutaneous CT guide RFA is concerned. So we have case selection is very important. The size of these lesions is very critical in relation to the kind of needle we are using, because as we can see in the first figure, there is a zone of ablation where we are able to effectively burn the lesion up to. It depends on the diameter of the needle, so also about the length of the needle. So in most of the standard needles, we are able to ablate area of about 3 centimeters. Recently, these special RF probes have been introduced. The multi-prong or the tine electrodes, which expand into an umbrella-like design once we have entered into the lesion for even bigger lesions up to 5 centimeter. Length of the needle also has it also affects the same. And even if we are not having these multi-prong electrodes, we can use a single needle electrodes and do ablation at multiple sites. So as far as percutaneous RFA is concerned, it is an established technique for benign bone lesions, as we have seen in osteoid osteoma, especially in the extra spinal locations. For the spinal locations, we do still prefer minimally invasive surgery, osteoblastoma and chondroblastoma, and it is a safe, effective, quick, no lengthy recovery is involved, no blood loss, much of blood loss, and success rate for the primary procedure is around 95%. For a secondary, if we are not able, if the lesion is not ablated in the first sitting, for the second ablation, the success rate is almost around 100%. Limitations can be constrained as far as this procedure is concerned, but when we compare it to an open procedure, the pros obviously weigh far more as far as the cons are concerned. And if we have an in-house ablation machine, the cost can be considerably reduced. So as far as the completeness of ablation is involved, yes, there are no certain factors where we can ensure that the lesion has been completely ablated, because clinical parameters like subsidence of symptoms like pain, it usually happens after 24 to 48 hours. There are no immediate radiological parameters. Yes, in an institutional or a teaching institute, we can do a pre-procedure PET scan and a post-procedure PET scan to see the reduction in SUV, but that again adds to the cost and logistical problems. Thanks for listening. Thank you very much.
Thank you, Dr. Jagandeep. It's a very nice presentation, and I think you have explained everything in such a lucid manner that everything is self-explanatory. Now we move on the next topic, that is role of denosumab in germ cell tumor, a medical oncologist perspective. And the speaker is Dr. Deepak Popka. He's from Hyderabad, and He is the radiation oncologist. At the same time, he is medical oncologist also. Right now, he is the consultant medical oncologist, Care Super Specialty Hospital, Hyderabad. Dr. Deepak, please just start your presentation.
Yeah, thanks for the introduction, sir. Yeah, okay, just share my screen once. Yeah, I hope my screen is visible. Hi, everybody. I would like to thank the organizers for giving me this opportunity.
You are visible.
Yeah, I think in a forum where there are a lot of orthopedic oncologists, a medical oncologist role is very minimal in tumors like giant cell tumors. So denosumab has a little role. According to me, I would prefer giving denosumab in patients who have unresectable giant cell tumors, not in the ones which are resectable. I would like to discuss on the clinical data we have with denosumab in this domain. Locally aggressive behaviors. 3 to 5% have pulmonary metastasis, which again have indolent behavior, and we term them as benign pulmonary implants. The peak incidence is in the 3rd and 4th decade of life, and the slight female preponderance. This comes from the data which is published in Lancet in 2019, where the highest number of cases, 500 plus patients, were recruited, and even in that study there was a slight female predominance. It originates from the epiphysis and adjacent metaphysis of long bones, and some flat bones can be affected, predominantly the pelvis and the spinal bones. Presentation is pain and swelling on the long bones, deformity and limitation of mobility when the spine and pelvic bones are involved. Histopathologically, disease is characterized by round to oval mononuclear cells, and these large osteoclast giant cells are implicated in the causation in pathogenesis of this disease. These are multinucleated up to 50 from monocytes, and more than 50% cellular content is present. So there is an osteoblast precursor from which malignant stromal cells are present, and because of increased rank ligand expression, there is recruitment of osteoclasts which form these giant cells. So treatment traditionally has been surgical resection with wide margins. Majority of the times we see patients having surgical curettage done with burring. This is most effective in long bones. Intralesional curettage for functional preservation, but the problem is this high recurrence rate. Studies say the recurrence rate is somewhere between 10 to 50%, wide range, but because of intralesional curettage, there is a high risk of local recurrence. And adjuvant filling with phenol, zinc chloride, and can be done. Radiation, there is improved local control as high as 80%, but the problem is sarcomatous degeneration is a problem with giving radiation to giant cell tumors, and could be avoided in patients where denosumab or any other therapy is being planned. There is some data from smaller studies saying that denosumab potentiates affect the sarcomatous change if radiation was previously given to these giant cell tumor, these GCTs. Now, coming to the normal bone physiology and what happens in giant cell tumors, estrogen and osteoblast form osteoprotein, and osteoprotein in the presence of rank ligand inhibit rank, and because of decreased rank expression, there is an arrest of osteoclast differentiation, which leading to apoptosis, and there is no bone loss. In females, this helps in skeletal integrity, and postmenopausal on patients on endocrine therapy like aromatase inhibitors, there is osteoporosis because of decreased estrogen presence. Similarly, in males, androgen, because of aromatase enzyme, the androgens, that is testosterone, is converted to estrogen, which also helps in bone preservation. And in patients like in prostatic cancer, where we do orchidectomy or do androgen deprivation therapy, there is bone loss, which eventually results. So, denosumab, it is used in various other tumors in solid malignancies like metastasis in breast cancer, multiple myeloma. It's an IgG2 antibody with high affinity to rank ligand, because of which rank ligand is denosumab binds to the rank ligand, and because of which there is no interaction with rank, because of which there is no bone destruction. So now, what is the emerging role of denosumab in the management of giant cell tumor of the bone? So excess rank ligand has been implicated in giant cell tumor pathogenesis, impacting the tumor growth and bone destruction. Denosumab specifically binds to rank ligand, inhibiting the formation of osteoclasts like giant cells. So these are the predominant cells which are responsible for giant cell tumors. This mechanism of action of denosumab directly impacts the bone biology, and giant cell tumor of the bone reducing the tumor growth and bone destruction. So these are the giant cells. Because of excess rank ligand expression, there is these osteoclasts like giant cells which are formed, which cause bone destruction and the tumor. Pre-existing hypocalcemia must be corrected before we give denosumab. This is very, very, very important. Unlike bisphosphonates, rank ligand inhibitors cause prolonged hypocalcemia, and the depth of hypocalcemia is way higher than what we see with bisphosphonates. So normal calcium levels are necessary before we go ahead with these agents. So this is the largest clinical data which was published initially in 2013 with the interim analysis again in Lancet Journal, and now the final data was published in 2019 November in the Lancet Journal. And so the primary analysis, sorry for that. Yeah, the primary analysis, it's a multi-center open label phase 2 study, and this study included patients from 2008 to 2016 for a span of nearly 8 years. Though giant cell tumor is a rare disease, there were really 532 patients who were enrolled. Cohort 3, it included a very small population, near less than 20 patients. This was patients who were previously, this was based on a previous phase 2 study, which evaluated the role of denosumab. Even this study population was included into the analysis. Patients received denosumab, but not the defined protocol way. Now, cohort 1 had surgically unsalvageable GCTV tumors. That is, tumors which were located in the spine, sacral bone, or multiple tumors with having pulmonary implants or pulmonary metastasis. So cohort 1 was surgically unfit patients. And cohort 2 were surgically salvageable patients, but the surgery would have resulted in severe morbidity because of the extent of surgery patients had to undergo. So the dose which was recommended was 120 milligram given once every 4 weekly. This is the study protocol. This is how the study protocol was designed. Because the intensity where every 4 weekly patient has to receive this injection, there is a new study called REDUCE, where we're trying to evaluate how much frequently the dose can be administered. Once every 3 months in the maintenance phase is now being evaluated, but currently this is still the practice which is being followed, where 120 milligram once every 4th week is given. Loading dose again 120 milligram is during the first month, is repeated on day 8, that is week 2 and week 3 also. A patient who had complete tumor resection, that is in the cohort 2, received adjuvant denosumab for only 6 doses after pathological confirmation of partial response or complete response. Prior to surgery, they were allowed to receive denosumab for a period of 3 to 6 months. Later, they underwent surgery, and on histopathological examination, if there was partial or complete response to the treatment, additional 6 doses were given up to 6 months. Along with denosumab, when in practice, at least 500 milligram of oral calcium and 400 international units of vitamin D is necessary to prevent symptomatic hypocalcemia. Some recommend doses as high as 1 gram of calcium during the course of denosumab therapy. So for all patients, treatment continued until disease progression, that is in cohort 1, or recommendation of discontinuation by the investigator or sponsor, or absence of clinical benefit to the investigator judgment, patient decision, pregnancy, administration of disallowed therapy. There was during the course of this study, which was 8 years, some centers had government approved denosumab available, so even those patients were removed from the study. So the cohort 1 was surgically unsalvageable patients. 267 patients were enrolled, out of it 264 received at least 1 dose of denosumab. Cohort 2 had 253 patients. The primary endpoint was safety analysis, so that was the only endpoint, whether denosumab is safe to be given in giant cell tumors or not. Secondary endpoints were time to disease progression in cohort 1, that is patients who were surgically not salvageable, and proportion of patients without any surgery at 6 months for cohort 2 patients. So patients who were potentially eligible for surgery, but because of the morbidity associated with surgery, if at 6 months if the patients were suitable for avoiding surgery, was one of the secondary endpoints. And the pharmacokinetic study as one of the secondary endpoint was there. Now for the cohort 1, it has excellent data where only 11% of the patients progressed during the treatment phase. So while they were on treatment, only 11% of the patients progressed. And the progression rate, if the patient had stopped denosumab, was more after 6 months. So at least the drug is effective for 6 months period. And if patients can tolerate the medicine and are surgically unfit for surgery, then I think continuing denosumab, there is very good chance that the disease can be controlled. Now coming to cohort 2, this is very interesting. This is where it is initial analysis where 92% of the patients in cohort 2 did not have disease progression at 6 months. So this is the majority of the patients didn't progress while they were on therapy. But disease progression at 3 years was seen in almost as high as 40%. That is literally more than 3 times than what we see in patients in cohort 1. That is patients who not underwent surgery. Patients who underwent surgery and received 6 months of adjuvant denosumab, nearly 40% of the patients progressed. So there were multiple hypotheses on why patients who underwent surgery after denosumab progressed. One of the hypotheses, patients after 6 months of treatment didn't have right ligand inhibition and eventually the tumor recurred. Second hypothesis, meaningful hypothesis, which I feel is because of rank ligand inhibition using denosumab, the osteoid giant cells undergo transformation into osteoid matrix. There is more waveform bone matrix which sets in, causing sclerosis, and probably during surgical resection. I think the surgical colleagues can pitch in here. Probably the surgical resection in patients who are potentially suitable for surgery, the surgical resection margins might not be well defined, because of which a small amount of tumor is left behind, and once we stop the treatment, there is a huge chance of recurrence. Now coming to the clinical benefit, predominantly.
Sir, sorry to interrupt. Kindly conclude your talk, please.
Sorry.
So kindly continue.
Yeah. So come cohort 1 and 2, there is 80% clinical benefit. That is pain reduction, improved motility, and improved function was seen. Reduction is seen in nearly 2/3 of the patient. And again, response rates were very high in cohort 1. Even stable disease was taken as a response rate in patients with cohort 1. So as we all know, this osteonecrosis of the jaw is one of the common side effects of this. Hypocalcemia, we should be really aware. And if patient present with atypical bone pains, hip pains, we have to see for tumor fractures in this group of patients while they are on denosumab. Sarcomatous transformation in less than 1% of the patients and who have undergone radiation. So denosumab shows good safety and long-term disease control in both unresectable and resectable tumors. The type and frequency of adverse events were consistent both in the interim and in the final analysis. Higher incidence of osteonecrosis of the jaw is seen, so dental screening is required before the patients go ahead for this therapy. Thank you. Sorry for the extra time.
Thank you. Thank you, Dr. Deepak, for your excellent deliberation. Now we move on the next topic, that is in the form of debate. The debate is when to cure it and versus when to resect in GCT. The first speaker will be Dr. John Mukhopadhyay. He is a very renowned orthopedic surgeon in the country. And right now he is the Director of Orthopedics and Trauma, Paras HMRI Hospital, Patna. And the second speaker is Dr. Sudhir Garg. He is Professor and Head Department of Orthopedics, Government Medical College and Hospital, Chandigarh. On this occasion, the experts is Dr. Akshay Tiwari. He is Head and Associate Director, Musculoskeletal Oncology, Max Institute of Cancer Care, New Delhi. So with this, I will invite Dr. John Mukhopadhyay to start his presentation, please. Dr. John.
Thank you, Dr. Singh. Someone needs to allow me to start my video before I, yes. So I think we tell the host to please start my video. I'll try to share my screen in the meanwhile.
Sure.
Okay, so I still can't seem to start the video, so I'll just go on with the talk. Is that okay?
It's okay.
We can see your screen, sir.
It's okay.
Okay, fine. You can see the screen. That's great. Okay, so I think the debate today is whether we should curate or resect in a case of a giant cell tumor. So we really need to look at what we are debating, or if there is a debate, because your decision depends on many factors. It depends on the site, the extent, the radiological signs, the risk of recurrence, and the functional deficit you're going to cause if you're going to resect the tumor. Okay, it's like debating nailing or plating in a proximal humerus fracture, and you have an X-ray like that. So no, even the most ardent nailer is not going to nail this fracture. But if you have a different fracture, something like this, yes, that's a fracture where you can debate whether you choose to nail or plate and maybe make sense out of it. But I think it just shows. So similarly, if you have tumor like this, a giant cell tumor in a young lady, you're not going to even think of curettage and bone grafting in something like that. You're going to end up having to resect it. And in this case, we decided to do extensive resection and an arthrodesis with a long nail and a fibular graft to get her over. And you can see at 1.5 years, things have gone on to heal well. But if you have a tumor like this, maybe there's a debate. Would you try to curate it, or you would bone graft it? You obviously would look at MRI. You need to confirm your diagnosis. But I think if it's a giant cell tumor, most of us in a situation like this would not resect this tumor, because it does lead to a problem with function, and you would curate it. Okay, now if you want to curate it successfully, you need to do an extensive, or what we call extended curettage. You need to use high-speed burrs. I think it's important. It makes a huge difference between just curating it and really using a high-speed burr to get rid of all the tumor. Make sure you use adequate windows so you can reach every nook and corner of the tumor. And you may or may not use adjuvants. I think today the evidence for the use of adjuvants such as phenol and liquid nitrogen is scanty. Okay, then you need to fill the cavity, and if you got adequate bone graft, you can use that. You can use bone graft substitutes. If you have access to allografts, that's great. Consider bone cement as another one, another thing. You can fill these cavities, and you need to check on the articular margin. And if there's a very thin articular margin, you can think of using the sandwich technique, which has been popularized by the Tata Cancer Hospital people. And you may need to add fixation if at the end of your extensive curettage, it is likely to risk fracture. So here's that patient who I showed earlier. So we did an extensive resection, extensive curettage with bone graft using a fibular graft. And this is her at about 8 months down the line. And she went on to do well and did not need any further treatment. Here's another gentleman with a lesion in the talus. Again, not a very common lesion, but if you have a lesion like this, you need to confirm your diagnosis. And in this situation, you would not try to resect the talus or the entire area. You would curate it adequately, put a bone graft, and this is him at 1.5 years, doing well with no recurrence and good function. Another case within the distal femur, again, you would do a thorough curettage, bone grafting, add some bone substitute in this case, and this is him at 1.5 years post-op, doing functionally well and doing well. Okay, this is a doctor about 40 years old who we used curettage and bone cement because he didn't want bone graft to be taken. And this is him at 1.5 years down the line, still doing quite well. This is an X-ray he actually sent on WhatsApp today to us. Recurrences, what happens if you get a recurrence? This was a patient who came to us from elsewhere where they had done a curettage and cement, and you can see the extensive recurrence there. Those are the sort of MRI pictures. That's the per-operative picture. And here, in this situation, of course, you have no choice. You need to excise the entire area. Here we did like a masculate technique. We filled that area with bone cement. This is at about 6 weeks down the line. You remove the bone cement. You have the membrane formed there. And there we used a combination of fibula, cancellous bone graft, and a titanium cage to fill the defect. That's what all we needed to fill the defect adequately. and also stabilize it, extending to the talus for our arthrodesis. And this was the post-op X-ray. And this is at about 2 years post-op. You can see she's functionally doing well and everything is going on to heal satisfactorily. So I think in conclusion, I think they're horses for courses. I think we can't use the same treatment for all giant cell tumors. The indications are different. These are not malignant lesions. Remember, they're although locally aggressive, are not malignant lesions. So where there is a choice and you have the choice between curettage and resection, definitely curettage would be your preferred option. Thank you.
Thank you, Dr. John. Very nice presentation, I must say. And now I will invite Dr. Sudhir Garg to start his presentation, please. Dr. Sudhir Garg.
Sorry.
Yes, Dr. Sudhir Garg, please.
Yeah, am I audible?
Yes, yes.
Yeah, thank you. I fully agree with Dr. John Mukhopadhyay. Sorry. I don't think my screen is okay. Can you see? Is my screen visible?
Yes, sir, it is visible, sir. We can.
Okay, okay. So thank you, Dr. Jagan, for your kind invitation. And I fully agree with Dr. John Mukhopadhyay that there is no debate whether to cure it or whether to resect it. So I don't know. Slides are not moving. Okay. So I would fully agree that in majority of patients, extended curettage remains the treatment of choice, even in very large tumors or when even there is a intra-articular pathological fracture, we can curate it and nicely reconstruct it. But there will be some conditions or situations where curettage probably would not be enough. If you can look at this X-ray, there is extensive bone loss, and this is a case of huge recurrence with a huge soft tissue mass, or a GCT in a expandable location, or the GCT in a complex where the bony anatomy is complex. So in my opinion, the case for resection would be if when there is a extensive bone loss, there is a large soft tissue mass, or there is a multiply recurring tumor, or even if it is first time but it's a large recurrence, or it's an expandable bone like fibula, distal ulna, or rib, or the anatomy is complex where you cannot do a thorough curettage. So these are the few representative cases. 29-year-old female with the GCT of proximal femur. You can see that the bone is totally destroyed and there is a fracture neck of femur. So we treated with wide resection and reconstruction using endoprosthesis. Another patient, 56-year-old female with huge GCT proximal tibia with virtually no bone left, again treated with resection and endoprosthetic reconstruction. This is a multiply recurred GCT of the distal radius with a soft tissue mass, again treated with resection and reconstruction using fibular autograft. And this is a GCT involving the pelvis, both the lower part of the ilium, acetabulum, and the rami, treated with resection and iliofemoral arthrodesis. So these are the situation where I feel that you would be left with no choice but to carry out a resection rather than the curettage. But there would be some cases where there is a debate. You can see these two cases. There is a very thin rim of bone left, which is interrupted at few places, but there is virtually no soft tissue mass. So how do we treat them? Are there any guidelines how we treat them? There are no definitive criteria available to decide whether to treat such tumors by curettage or resection. But there are a few papers available in the literature. This is from Robert Turpin and published in 2006, and they concluded that many stage 3 tumors or cases where there is multiple local recurrences or there is a pathological fracture when joint anatomy cannot be restored, that cases would require resection. Similarly, this is the paper published from Tata Cancer Institute on the algorithm of treatment of bone tumors. And they have concluded that you need to ask this question: will there be adequate cortical bone after intralesional curettage to maintain or restore stability? If the answer is no, then that case is fit for excision and reconstruction. And this is another paper from William Ward published in Clinical Orthopedics and Related Research on customized treatment algorithm for giant cell tumor, treatment of giant cell tumor of the bone. And they have concluded that if more than 50% of cortex is destroyed, more than 80% of cross-sectional bone is lost, more than 50% of articular surface is destroyed, and there is extensive soft tissue extension, then there is a case for resection and reconstruction. But these guidelines, they are likely to change because the introduction of bisphosphonates like zoledronic acid and denosumab. And this is a paper published again from Tata Institute, and they have concluded that the denosumab may help in converting a lesion requiring resection to a lesion that could possibly be treated with curettage. So these are the just few representative cases, stage 3 GCT, with a very thin rim of bone left, which is interrupted at few places, but there is no significant extraosseous soft tissue mass. So again, treated with curettage and just the zoledronic acid, and you can see the proximal humerus has reconstructed and he has good function. Again, another patient, stage 3 GCT, with breach of the cortex on the medial side with large soft tissue, extraosseous soft tissue component, again treated with denosumab, resulting in formation of a osseous rim, and then we could treat it with curettage. And this is a case I treated about 15 years back, 68-year-old male with the GCT of proximal tibia with a pathological fracture. At that time, I treated this patient with resection and endoprosthetic reconstruction, but probably now with availability of denosumab, I may be re-looking at such cases and may give a trial of denosumab before going for resection and reconstruction. So to conclude, the main purpose of any treatment is that we must be able to adequately remove the disease to minimize the chances of local recurrence. Extended curettage is still the treatment of choice whenever possible. Resections are rare but needed if there is extensive bone loss, there is loss of tissue mass, or there is intra-articular extension, or the joint surface is destroyed and you cannot reconstruct it. And we should also look at the role of adjuvant therapies in selected cases, because it's promising in downstaging the disease, which can convert a lesion from a resectable to a curatable. And at the same time, if we are going to resect it, it also helps in the resection. Thank you.
Very nice presentation, Dr. Sudhir Gar. And now this is the time for Dr. Akshay Tiwari for his expert opinion. Dr. Akshay, please.
Yeah, thank you, Dr. J.K. Singh, for letting me have some comments. And it was a pleasure to witness this debate. And I must admit, it was hardly a debate at all. I've never seen more affable and friendly debaters before this debate. I think both the debaters would agree to the same point as to when to resect and when to curate. I'll start my video. Yeah. So basically, I guess both the debaters came down to the conclusion that it's the site, the radiology, the Campanachi stage, the age of the patient, whether there's a pathological fracture or not. And as very importantly put forward by Dr. Sudhir, whether you are left with enough bone stock after you curate is what will decide whether you'll curate or resect. As Dr. John said, most of us would want to curate rather than resect, because we have to remember this is a disease with a very good prognosis longevity wise, and the patient is going to have his own joint in case we curate, and that is what we all want. A very important thing that we must remember and is often missed is a patient's wish. A lot of times patients get fatigued of recurrences and they push us towards resection or otherwise. their occupation, their expectations from the surgery, and their age will also decide whether we want to curate or resect. And it's quite often a mutual decision. One word of caution for curettage after denosumab, and I think Dr. Sudhir will agree that most literature is pointing towards a little higher rates of recurrence in case we go for curettage after converting a soft tissue shell into a bony shell by using denosumab. People are arguing whether it's the conversion of GCT into thick bone that leads us incapable of differentiating between bone and disease that is leading to the recurrences, or these are anyways high risk cases for recurrences, and that's why recurrences are more common. So that debate continues, and maybe that is the debate we can have the next time on whether to use denosumab before curettage or not. I think, thank you. Thank you, both the debaters, for bringing out very important points, and I congratulate both of you.
Thank you. Thanks, Dr. Akshay.
Thank you, Dr. Thank you, Dr. Akshay, for your nice remark. And now, once again, we move on to the next topic, that is the reconstruction options in limb salvage surgery. What is new and what we already know. And the speaker is Dr. Avjit Solanke. He is the consultant orthopedic oncosurgeon in Gujarat Cancer and Research Institute, GCRI, Ahmedabad.
Good evening, sir.
So, Dr. Avjit, please.
Thank you, sir. Thanks to the organizers for giving me opportunity to speak in front of all the audience, and would like to present reconstruction options in limb salvage surgery, what's new and what we already know. So this is the slide showing that what are the previous reconstruction option. On the left side, we can see Bhagwan Dada, so singing the song, and on the right side, we can see Tripathi ji. So it's past and present, and future we don't know what reconstruction options will be available in future. So we'll be discussing what are the reconstruction options available in limb salvage surgery, and what are old options and what are the new options. So there are two options all available after limb salvage surgery. One is limb salvage surgery followed by reconstruction. So we can use biologic methods, non-biologic methods. And in amputation, we have modified amputations also. So again, on the left side, we can see the newer techniques. That is a expandable megaprosthesis, which is a recent technique which is used commonly, and it's a minimally invasive type of expandable megaprosthesis. On the right side, we can see a distal proximal tibia tumor which was resected and reconstructed with a megaprosthesis. So that is older one, and on the left side we can see the newer technique. So we have two treatment options. One is non-biologic, that is a use of a megaprosthesis after resection of proximal humerus tumors or any tumors around the joint, and we have option of a biologic method. So here an example showing ECRT, that is extracorporeal radiotherapy, and the tumor was resected and the bone was treated with radiotherapy and fixation back with the help of a plate and screws. So again, a case example, tumor of proximal tibia, osteosarcoma, which was treated with neoadjuvant chemotherapy. Tumor was resected with good margins, and reconstruction was performed with a megaprosthesis. So the megaprosthesis previously available were customized joint. After that, there was an era of modular megaprosthesis. So this is a modular megaprosthesis which is used having few components that can be femoral component, tibial component, a stem which goes into the femur and tibia, and all parts are arranged on table. So it's a modular type of megaprosthesis that is available and used all over the world nowadays. So this is the example of this patient showing the radiograph and his post-operative function. Next, we will see an example of a biologic method. So again, a rare tumor involving the calcaneum bone, and this was a 17-year gentleman with mesenchymal chondrosarcoma treated with neoadjuvant chemotherapy, and plan was to do limb salvage surgery. So we planned this case with the help of a 3D printing. So on the left side, we can see insect making a cocoon. So this is example of how 3D printing works, and we made a model of this patient and planned the cuts. So upper cut was from the talus, posterior cut was just ahead in front of the tendoachilles, and anterior cut was planned, and the tumor was resected. And the curve which was made after giving ECRT to this bone and with the help of a vascularized fibula was placed into the trough. And this is the final radiograph, and Herbert screw and suture anchors were used to attach the tendoachilles to the calcaneum, and screws were placed from the calcaneum to the talus, and vascularis fibula was placed. So example of a biologic method using two biologic method. One is ECRT and second is a free fibula or vascularis fibula. Third example, we can see use of a mesh. So a proline mesh can be used if it was a tumor involving the articular area, means involving the acetabular region. So here it was type 1 plus type 2 hemipelvectomy, resection of ileum and the acetabular area. A reconstruction was performed with the help of a proline mesh. So what modern techniques are available nowadays, we can plan a customized 3D printed joint of the acetabulum and do THR. So a reconstruction can be made with this method. And this is the previous method, which is commonly used still nowadays. It's good method, giving a pseudo arthrosis. So this was the post-op CT scan of this patient. Then an example of reconstruction with the pedicled cryosurgery. So use of liquid nitrogen. This is a small video showing how liquid nitrogen is used for these patients. So it was a case of diaphyseal humerus. So this is the tumor which was resected. This is a small animation prepared. So a proximal cut is given. And the elbow is turned upside down so that that bone can be placed into liquid nitrogen. So we will be getting a cut only in the proximal part. And this is example of a pedicle type of liquid nitrogen technique. Other technique available is intercalary technique. So this is how the elbow is turned upside down and liquid nitrogen is placed. So liquid nitrogen at minus 120 degree for 20 minutes. So going to the case scenario, this was the X-ray of the patient. This was the X-ray post-op. This was MRI. This was the skin incision. And this is how the tumor was resected. And we remove all the soft tissues of this patient and make multiple holes into the bone. And we will try to dip the bone into liquid nitrogen. So this is the method how liquid nitrogen is placed into a sterile container. And this is how liquid nitrogen is placed. So it's available at minus 190 degrees and placed for 20 minutes. So this will kill all the tumor cells. Then the bone is thawed. So this is the bone after treatment with liquid nitrogen. And we'll be fixing it with the help of a plates and screws. So this is summary of this case. So this is the last slide. We'll be showing two examples what was done in past and still it is continued, that is rotation plasty. And on the right side, we'll be showing total femur expandable megaprosthesis. So total femur was involved and it was treated with chemotherapy. So good response to chemotherapy. So plan was to do limb salvage surgery. So total femur is excised. And on the left side, we can see the femur and proximal part of tibia is excised. So this is the resected specimen. And here we can see the preserved neurovascular bundle. This is the growing joint or expandable joint. So this is minimally invasive type of expandable megaprosthesis. And here we can see the implant is placed inside and we'll be showing how the expansion is performed for these patients. On the left side, we can see that there is coiling of the neurovascular bundle and we'll be applying a plate. So this is the picture showing the screw. A small incision is given and this part will be expanded. So we can achieve maximum 5 to 6 centimeters of expansion with these implants. On the left side, we can see plate is fixed from femur and tibia for these tumors. And this is the functional outcome of this patient. So this is the kid and he is walking with the prosthesis. So this is how expansion was performed. So you can see what was done in past and still it's significant. And on the right side, we can see the newer technique. So this is how the patient will be moving his ankle joint, which will be working as a knee joint for this patient. So thank you very much for your patient listening and thanks for giving me opportunity to speak in Paras Cancer Conclave. Thank you very much. Thank you, sir.
Thank you, Dr. Abji. for such a nice presentation and nice videos also. And now we move on to the second debate, which is STS extremity. And that is about post-operative RT. Old is gold. For Dr. Nihal Khanna, he will be for, and the guest is Dr. Indu Bansal. She is from Gurgaon. So Nihal Khanna is the professor and consultant radiation oncologist, Tata Memorial Hospital, Mumbai. And Dr. Indu Bansal Agrawal, she is the director and the senior consultant, radiation oncology, Narayana Super Specialty Hospital, Gurgaon. So I'll request first Dr. Nihal Khanna to start his presentation, please.
Hello.
Ma'am, we can hear you. We can see your screen also.
Yes, Dr. Nihal.
Yeah, I think there's I had logged in.
There is echo in the voice, ma'am.
Okay, I think I'll just come out. There's some problem with my, okay. So I will conduct it from my mobile. Is that okay? You can operate my slides accordingly.
Ma'am, now the voice is clear.
Now the voice is clear, but I'm on my laptop and not on my, I'm on my mobile and not on my laptop. So I think you can move the slides. The last minute, there was some internet issue. I thank the organizers for giving me the privilege to be a part of Paras Cancer Conclave. Next slide, please. Next slide, please. Radiotherapy plays a very important role in the management of extremity high-grade soft tissue sarcomas. The premise of limb salvage is set on the strong backbone of post-op-RT, and since the time of the first randomized control trial published in 1982, the NCI trial, we have gathered an experience of more than 4 decades for post-op-RT. Next slide, please. The only study, next slide, please. Next slide, please. So the only study which evaluated prospectively head-to-head comparison between pre-op RT and post-op RT showed a non-statistical improvement in overall survival with post-op RT, but the trial was not designed to show survival benefit. Next slide, please. A lot of patients in the post-op RT arm had deviations of radiotherapy. And if we go very much into detail, we realize that more patients in post-op RT arm had non-sarcoma or non-treatment related or toxicity related death. Hello?
We can hear you, ma'am.
Yeah, can you please change the slide?
I'll request Manas or Surbhi to coordinate, please.
I'm really sorry for this last minute technical thing.
Manas, sir.
Yes, we are moving.
But
Yeah,
slides are not moving.
So this 800 patient database showed that pre-op RT is associated with significant improvement in all oncological outcomes. Next slide, please. But this study was marred by extreme heterogeneity of radiotherapy doses. But if we look at this large database of more than 10,000 patients, it is shown that radiotherapy improves overall survival and the timing of radiotherapy is not associated with a significant difference in outcome. Next slide, please. So we'll not fight on the efficacy of pre-op versus post-op RT. We know oncologically both are same. Post-op RT is associated with more long-term side effects like fibrosis, edema, and arthrosis, essentially because of larger volume and higher doses, but it seldom requires major intervention. But proponents of pre-op RT always say that these wound complications are acute and they eventually heal. So this side effect is not permanent. Next slide, please. But let's get into detail of this wound complication. Almost 2/3 of these patients will have wound complications, and around 1/3 of them will have significant wound complications. And if I say significant wound complication, it means surgical debridement, secondary wound closures, requirement of IV antibiotics, prolonged hospital stay. Next slide, please. The duration of wound complications may even go up to more than 300 days with an average of around 76 days. So these certain sites like lower extremity, the distal lower extremity is associated with prolonged healing issue. So this temporary nature of wound complications is probably not acceptable in our scenario. Next slide, please. 1/3 of these patients will require plastic reconstruction. Hello? Hello? Next slide, please. 1/3 of these patients will require plastic reconstruction, and the expertise is not available in all centers, and it definitely adds on to the cost. Next slide, please. The investigators of the SR2 trial in the subsequent prospective study tried to determine the scar and underdose that scar were also associated with significant acute wound complications. And in our context, when the tumors are large and are close to the skin, we mostly, in most of these cases, would not be able to underdose them. Next slide. And how do we reduce these wound complications? Multiple publications addressing role of conformal radiotherapy, adaptive radiotherapy, and image-guided radiotherapy hasn't helped in reducing the wound complications to a significant level. Next slide, please. Post-op RT is easy. It mostly requires a 2D treatment planning. Pre-op RT, with its major requirement of conformal RT, adaptive radiotherapy, and image guidance, not only adds on to the cost, but also is an added burden to our already crippled system. Next slide, please. And all of this adds on not just the morbidity and the cost, but also adds on to the subsequent reduction in the quality of life. Next. We cannot plan pre-op radiotherapy without an access to a multidisciplinary team under one roof. Most of the centers do not have access to multidisciplinary care. And in our country, where the surgeons fear that they would lose their patients if they refer the patient to for pre-operative radiotherapy, they may lose it to some other surgeon later on, would actually want to operate upon these patients upfront and then refer for post-op RT, and which is actually the most common scenario in our country. Next slide, please. And the conundrum of positive margins once pre-op RT is given, nobody actually knows whether to give, to not to give, but if at all extra dose of radiation is given, it is associated with significant side effects. Next slide, please. This SR2 trial, the late radiation morbidity, it was seen that post-op RT was not associated with significant difference in joint stiffness and edema. Next slide, please. The ghost of post-op RT do not exist in the conformal therapy era. We very well understand how to reduce the V100 of the femur, the soft tissue, and the skin with the use of IMRT. In our institute, we do use CT planning for all our patients, but most of these patients are treated with conformal 2D portals. Next, please. The volumes and the doses are evolving with post-op RT. Thanks to the Vortex trial, the volumes are not that large anymore. Nobody gives more than 5 centimeter margins these days. We also have an understanding of certain histologies that do not require that kind of dose. And we have a better understanding of dose constraints of bones and adjacent soft tissue. Next slide, please. And with this kind of a treatment, we do not expect that kind of side effects. Brachytherapy is the most conformal treatment ever. It is the best way to offer post-operative radiotherapy and probably the best for children. Next slide, please. This data from our institute, Dr. Siddharth Laskar's paper, in around 105 children shows very good outcomes and very good complication profile. Next slide, please. India has a very strong legacy of brachytherapy and a strong future as well. And there are a lot of centers that practice radiotherapy for extremity sarcomas in our country. Next slide, please. So is there a role of pre-op RT? Definitely not in all comers, but yes, in certain select patients wherein at the time of a multidisciplinary team discussion, it is deemed that neurovascular bundle is closed and doing surgery upfront may actually compromise the margin, should be offered preoperative therapy in an attempt to make the surgery easy, make the tumor more resectable, and have a negative margin at the end of pre-op RT. Next slide, please. Radiotherapy post-op RT, with our experience of more than 4 decades, has stood the test of time. I strongly believe that it is standing tall and proud. Still, it's the real goal. And in nowhere near future do I see pre-op RT running on prime time in our country. Thank you. And I'm really sorry for the technical issue.
Thank you.
No problem.
No, it's okay. It's okay, Nehal. Thank you, Dr. Nehal. I think it's a very nice presentation. Now, for against, I'll invite Dr. Indu Bansal. Dr. Indu, please.
Yeah, good evening, everyone. And first of all, I would like to thank Paras Cancer Conclave for having me here. And I must say that Dr. Nehal has done my job so much easier because she herself agreed to most of the points of debate. Let me start sharing my screen.
Yes, Dr. Indu, please start.
So I know Dr. Nehal is very much confused. She's smiling, but she's confused because she also knows that pre-operative radiotherapy is the treatment of choice for extremity soft tissue sarcomas. And now we are talking about lower extremity sarcomas, and we see 46% of the sarcomas, they occur in lower extremities and 15% in upper extremities. And role of radiation has been confirmed. The only issue is pre-operative RT versus post-op RT, because local recurrence rates approach 20% even after the treatment. Now, I wanted to tell my dear friend that the most important goal in a treatment of soft tissue sarcoma is not just improving survival or to prevent local recurrence. I think the main goal is limb preservation, function preservation, so as to minimize the morbidity. And she did not touch upon the side effects of late toxicity with post-op radiation. And we know that the quality of surgical margins is the strongest predictor of early death. Now, role of radiation was confirmed by NCI trial. I'm not going to speak on this. About this, another trial which was published in 1998 by NCI, this also confirmed the role of radiation. And of course, brachytherapy also improves local control. And she spoke about brachytherapy, but we know that we don't, the question here is pre-op RT versus post-op RT, and not how brachytherapy can improve results after surgery. So now we know that when we give radiation, then in high-grade soft tissue sarcomas, local control is improved by 85 to 90%, and in low-grade sarcomas, it is improved by 90 to 100% if there are bad prognostic, if there are bad features like positive margins, age more than 50 years, size more than 5 centimeter, uncontaminated surgical bed, intact fascia, and all these. So SEER database suggests a modest survival benefit also for the benefit of radiation. We know about the target definition. In pre-op RT, the margins that we use are 4 centimeter longitudinally and including peritumoral edema. while in post-op party, the dose is higher, which is to the tune of 60 to 66 gray. And it's not just 4 centimeter margin that we use, but also the immediate area of surgical disruption is included. We have to include the biopsy site, the scars, and the drain site, which means that we are giving not just a higher dose, but also we are doing we are increasing the volumes and length of treatment. So I will talk about this vortex trial also. So if I talk about advantages of pre-op party versus post-op party, I think the whole session, this whole evening will end with this only. So if the dose is lesser with pre-op party, target volume is much smaller, target delineation is much easier, the sterilization of microscopic disease is possible, image guidance of visible tumor can be done easily, the induction of pseudo capsule is possible, and the probability of negative margins is also more with pre-op party. I agree that wound complications are more. I think that's the only drawback of pre-op party, but a recent study has shown wound complication rate to be reduced by 7%. And mind you, these wound complications are seen mainly in lower extremity, and we cannot generalize it to upper extremity as well. Also, counting again the advantages, the subcutaneous fibrosis is less, edema is less, joint stiffness is less, bone fractures are less, and cost and length of treatment. If we are talking about India, then of course that is also a very, very important factor, and that is also linked with the pre-op party. And the option of translational research is also there with pre-op party. My dear friend is forgetting the Hippocratic oath, and she is forgetting that the first rule of radiation oncology is first do no harm and follow the LRA principle, means give lesser dose, less volumes wherever is possible. So if we talk about that, then I think we should not even give post-op radiation at all. Now, talking about this SR2 trial, we know that the regional failure, distant failure, PFS, overall survival, both are similar between pre-op and post-op party. Wound complications were definitely higher and more so in lower extremity. And Dr. Nehal also agreed that these side effects are transient, reversible, and avoidable. But if we talk about post-op party, then these side effects are persistent, they are not reversible, they are lifelong, and they adverse the quality of life. And if we talk about wound complications, even in post-op party, the deep wound packing was 40% with post-op, and other invasive procedures were also 25%, which is more than pre-op. So wound complications were also more with post-op party. Also, we know from various studies that if you include more than 50% of joints, it leads to joint contracture. If the volume of tissue radiated to more than 55 gray is more, it leads to poor function. If the dose is more than 60 gray and the field length is more and lower extremity, then fibrosis is more. And if you give more than 63 gray, it leads to severe edema. And this is what exactly we are doing with post-op party, where we are giving 60 to 66 gray. That is the reason for all the late toxicities. And so often we see such patients who have come with such weird scars. So I think rather than discussing about pre-op party versus post-op party, we should rather talk about good surgeries, which is more important in a setting than discussing about disadvantages of pre-op party. Now dose painting is possible. The 3D CRT and IMRT control rates are same, and O'Sullivan has already shown that with IMRT flap sparing technique, the wound complications are decreased, and IMRT decreases the mean and average doses to femur by 31%. So IMRT would be beneficial both for pre and post-op party. It does not matter whether it is pre-op or post-op. IMRT decreases the plans by V100 by 57%, V100 of surrounding tissues by 78%. And in fact, in the PMH trial, the boost was not given, and flap was contoured as a region of interest, leading to decreased toxicities. Now, this RTOG trial clearly showed that after post-op party, pre-op party, there was 86% R0 resection rate, and the post-op boost was needed only in 15% cases and not in all the cases. Now, and with IGRT, all these late side effects were reduced, not just the acute toxicity, but the late effects were also reduced. Now, my dear friend said that nothing is known about in which cases we should give radiation. What do you mean by positive margins? So let me make it clear that if we have to give radiation, all the positive margins are not same. So post-op RT is needed only if there are margins positive after re-excision, after a prior unplanned excision, or an unplanned positive margin surgical error, and not in a planned positive margin against an anatomic fixed critical structure. And also, if even if there are positive margins, then there is a role to give pre-op unplanned positive margins. The role is to give pre-op RT and then re-excise. And even in such a setting, the role of post-operative RT does not come. So boost is beneficial only in positive margins after unplanned excisions. Now, preoperative chemotherapy also doesn't help because the toxicity is very high. And she talked about histologic specific treatments. So let me tell you, in chemotherapy, even in a randomized trial, there was no benefit seen with standard or histologic specific chemotherapy also. Now, talking about Vortex trial, definitely in a post-op setting, the margins were reduced. But if my dear friend would notice that there was not much difference in the late toxicities, even with reducing the margins in a post-op setting. Now, coming to pathological responses. After pre-op RT, we see median responses in low-grade tumors to the rate of 67.5%, and in high-grade tumors, the rate is 50%. And in fact, if we talk about myxoid liposarcoma, we see 82% responses, which is not less, and that you see only with pre-operative radiation. Now, this is a table which will make everything clear. So we see that wound complications were 35% in NCI pre-op treatment, and but in post-op it was 17%. In PMH trial, it reduced to 30.5%. And in fact, now we have option of short course pre-operative RT also, where only 5 days radiation is given, and the wound complication rate, even with such a high dose, is to the tune of 31% only. While in Vortex trial, after post-op RT, even then the wound complication rate was very, very high, and the test decreased to 97%. And
Could
if
you
we
please conclude your talk, ma'am? Sorry
just
to.
last slide. So pre-op RT with IGRT has reduced the late toxicities also, and not just the pre-op complications. NCDB database has shown that the use of pre-operative RT has increased over time from 16.8% to 29.7%. Even NCCN gives pre-op RT as a category 1 recommendation. So I feel that the issue of wound complication has been blown out of proportion. This is transient, reversible, not in control of radiation oncologist, can be minimized by delaying surgery by 6 weeks by use of wound vacuums and flaps, and by avoiding flap exposure during RT. So the risk of bone fracture is 9 times more with post-op radiation, and these patients never recover. So we have to focus on saving joints, saving a skin corridor, and also saving the nerves, which is possible only with pre-op RT, because the dose should not exceed more than 60 gray. So, and coming to my last slide, the cost-effective analysis. This is a recent analysis published in 2016, which showed that pre-op RT is most cost-effective strategy than post-op RT. So I would just say that pre-op RT is time-tested. Overall survival and local control rates are similar. We see path responses. It follows oncology principles. It leads to some early toxicity, but it is reversible. Late toxicity is less, and it is cost effective. So my conclusion would be pre-op RT was there, is there, and will stay. Post-op RT was never there, and it's time to say goodbye to it. Thank you.
Thank you, Dr. Indu. I think it's a very nice presentation from your side. I think I'm sure you will also agree with me that for application of any modality of treatment, selections of the patient is very, very important. You have to select the patient for any modality. And at the same time, you have to see your infrastructures also in your institute. What are the infrastructure you can provide? So these two things, I find that these are very important. So thank both of you, Dr. Nehar and Dr. Indu. Now we move on to the next topic, that is 3D printed custom-made implants for bone sarcomas, and the future is now. The speaker is Dr. Himanshu Rohela. He is the consultant orthopedic oncologist Rajiv Gandhi Cancer Institute, Rohini, Delhi. Dr. Himanshu, please.
Thank you, sir, for the introduction. And I'll just start sharing my screen now. Is my screen visible?
Not yet, Himanshu. Now it
Yes,
is
your
visible.
screen is visible.
It's visible now?
Yes.
Yes, yes.
So I'll start
But
my
it's
presentation now. Yeah. So good evening, everyone. And I'll thank Paras Cancer Conclave for giving me this opportunity. And I'll be talking about 3D printing and its future. So the first slide would be why innovation is so important. Because we all know that with evolution, innovation goes along with it. With the dawn of extremity sarcoma surgery, it was always dominated by an amputation surgery. But now with the innovations and improvement in chemotherapy and radiation, there's been a shift from amputation to limb salvage surgery. Now, limb salvage surgery has two parts, the surgical wide resection, and the second part is the reconstruction. So we have done some innovations in the resection part also, like computer navigation planning, like use of 3D printed cutting jigs. And now the most recent one is the augmented reality use. When coming to the reconstruction part, metal prostheses also have evolved from hinge prostheses to rotating platform prostheses to expandable prostheses and now customized 3D printed patient-specific metal implants. So I'll be discussing my talk, use of 3D printing in orthopedic oncology under three broad spectrums. First one is the use of 3D printed jigs for cutting of the sarcoma part. Second thing would be the use of printed jigs plus as well as a printed implant. And the third, which is the most recent one, would be use of printed jigs plus a printed implant plus the use of intraoperative navigation. So we all know that 3D printing has improved accuracy in pelvic surgeries. We also know that 3D printing also improves extremity sarcoma resection with the help of causing less blood loss, shorter operative time, and reduced radiation exposure. Now, going back to the first case, as I told, we'll discuss in three spectrums. So a 19-year-old male, pain and swelling in the left lower thigh since 3 months. MRI showed enhancing lesion in the left distal femur. You can all see the X-ray where there's a lytic lesion, and on the right, there's an MRI with an enhancement in the metaphyseal region. So this is a CT and MRI fusion image, which we use to create a 3D printing software. With the help of that, we design the printed model of the bone. So this is how we design. This is the tumor part. And this is where my jig, how my jig would be prepared for the resection part. So this is the final jig which we get, the 3D printed osteotomy guides, which would help in the resection of sarcoma. And this would be the final reconstruction with the help of biologically retreated bone and a nail in between. Second case where we use 3D printing jigs as well as a 3D printed implant, a 24-year-old male, pain in the right hip, lytic lesion in the periacetabular region. You see this side, there is a huge lytic area in the periacetabular region, and MRI also shows enhancement in that region. So now whenever a patient is having a pelvic bone tumor, it has a great impact on quality of life. How to accurately fill the defect is great challenge. So routinely what we do, as Dr. Abhijit also showed, we do no reconstruction of the defect. We pull it up and cause a pseudoarthrosis, which would result in severe shortening and bedridden for 7 to 8 months. So this is what Dr. Abhijit was talking about. Like we pull up the femur and tie it around the pelvis with the help of marceline tape. Now we performed a 3D printed periacetabular resection guide as well as a reconstruction to customized prosthesis. This involved designing of the jigs plus post-resection model, and then we design the implant which we want to fix. This is the final implant which we get. This is the patient positioning, intraoperative guides, how we use to, how 3D printing helps us in accurate resection. The final implant, we prepare the implant by a Prolene mesh or a nylon mesh as a pseudo capsule around the joint. This is post-implantation. And then we check the intraop stability of the implant. This is the immediate post-operative X-ray with the hip side of the hemipelvis reconstructed with a metal implant. This is assisted walking on day 5th in comparison to a patient who would be bedridden. So this is 2 years post-operatively. Patient does not have any recurrence. 2 years follow-up of a patient with no limb length shortening and no recurrence. So in conclusion, there is a 2-year follow-up with no implant loosening, no recurrence, no periprosthetic infection, and no limb length shortening. So now my next thing is, how accurate is 3D printing and can I improvise it also? We all know that the positioning of this guide is a task which is decided by the surgeon, and therefore there would be errors in when we take human factor into account. So we also know that intraoperative navigation also improves resection accuracy. So why not to combine both of these, 3D printing and navigation? So this formed the basis of this study, where they showed that benefits of conglomerate technique, which avoided the errors in real-time surgery. This formed the basis of a cadaveric study which was conducted and showed that CT based navigation system improves the accuracy of these 3D printed cutting jigs in resection. With this basis, I'll present the third case. A 11-year-old child, pain in the swelling in the right upper arm since 3 months. This is the MRI lesion. This was a case of Ewing sarcoma. This is pre-chemotherapy MRI. A needle biopsy Ewing sarcoma. He started on neoadjuvant chemotherapy VAC-IE based. This is post-chemotherapy MRI. The response to chemotherapy was very good. So we decided to do a limb salvage surgery. This is the 3D printing where we decided physis to be the barrier. And this is how it decides where we need to cut. This would be the jig, which I'll design. But the accuracy of placing this jig was difficult. So we also designed an implant for this patient because the proximal fragment was too small to hold the plate. This is intraop navigation system. How we used this to place my proximal cutting jig to increase the accuracy of my proximal cut. With this navigation and 3D printing, I also know what kind of screws, the length of the screws. This is the specimen. We used liquid nitrogen in this case to treat it, to cryo treat the resected bone. And then we reimplanted this bone back. And this is the site of attachment of subscapularis muscle. You would see the subscapularis muscle coming back over the joint and the plate on the lateral aspect, posterolateral aspect. This is the final X-ray. 2 months follow-up, no local recurrence, no signs of implant failure. And this is, 1 second, I'll show you the function. This is at 2 months. The proximal fragment was too small. We've reconstructed all the ligaments and he's got abduction also. Thank you.
Thank you, Himanshu, for
Thank you, Dr. Himanshu. Thank you very much for your nice presentation. Now I'm seeing Dr. Tejinder Kataria. She has also joined here. She's co-chairperson of this session. So I request Dr. Tejinder Kataria to take up the introduction part of 2-3 speakers, if she can do it. Dr. Tejinder, you have to introduce the Pramod Chinder from Bangalore.
Thank you, Dr. Jacob. And
yes.
The next speaker is Dr. Pramod Chinder from Bangalore, HCG Hospitals.
Yeah, true.
He will be talking about the role of computer navigations and robotics in management of pelvic and sacral tumors. Over to you.
You need to increase the volume of your system.
Your voice is not very audible.
The next speaker is Dr. Pramod Chinder, and
yes,
he will be talking about the role of computer navigation and robotics in management of pelvic and sacral tumors. Over to you, Dr. Chinder.
Good evening, everybody.
Dr. Pramod, please.
Yes. Am I audible and can I see?
Yes, sir, absolutely.
Yes, you are audible.
Good evening, everybody. Thanks, Dr. Jitendra, for this opportunity. And so I'll just quickly move on to the presentation. It is a good presentation by most of the speakers. Himanshu, Manish, Abhijit. So that was really nice fun. So coming to the pelvic tumors. So we all know the pelvic tumors. My screen is visible, right, for everyone?
Yes, sir, it is visible.
Yes, yes. So coming to the pelvic tumors, we know the complexity of these issues. So in these, we have a learning curve. We have had our own learning curve in over 200 or 250 plus pelvic surgeries, what we have done. So in this, what we have come to a conclusion is, so pelvic surgeries have to be planned thoroughly. With the advent of 3D printing, navigation, and robotics, I'm sure pelvic surgeries will go to a next level of outcomes. That is our thought. So we use all these methodologies to make sure the outcomes are absolutely nicer. So that's what we call them as hybrid approach. So
can you go to full screen mode, sir, please?
Okay, yeah, sorry. Thank you. Yeah. Hi, Jagan, is okay?
Yeah, it's fine, sir.
Yeah. So as I said, so with the help of 3D printing, navigation, beautiful imaging tools nowadays with 3 Tesla MR, CT scans, I think the pelvic surgery outcome should be to the next level. I'll just go to a few cases. What happens is, through the case examples, I can tell you. So with all these examples, what we have achieved is, particularly the blood loss have been reduced to significantly lower levels, and thus the outcomes, and also the precision of surgery and the salvage of joints, so that the patient's activity or the morbidity is extremely low. So I'll go, this is one of the first case examples. So 38 years old guy who had multiple osteochondromatosis, one of which was a chondrosarcoma of the right ilium. All these other surgeries were all because of various multiple osteochondromatosis, multiple enchondromatosis earlier. He had one right-sided iliac chondrosarcoma which turned malignant. For that, he had a huge mass. This is a CT scan of the same. And if you see the MRI, there's a huge mass on the right side of the ilium. So for the same, if you see the axial section, so it is going extending up to the sacroiliac joints. So the standard workup has been done, the CT guided biopsy, proves to be chondrosarcoma, and we plan for a non-block resection. So yeah, so all like I said, so we follow 5 point principles in pelvic tumors. Number 1, all patients go through the embolizations, pelvic tumor. Even in spite of chondrosarcomas, they have less vascular, but they'll have a lot of surface vascularity, unless it's a grade 1 chondrosarcoma. So all go to the pre-op embolization, intra-op radiofrequency, radio energy devices, and save the blood from the word go. That means we don't wait till the blood loss happens. And the use of navigation, use of 3D printing, and hypotensive anesthesia. So do the pre-op embolization. Then we do a second day, we do anterior robotic release, and third day we do the pelvectomy or a sacrectomies. So this is embolizations. This is pretty vascular in spite of that. So this is a day 2 when we do the robotic anterior release. Here is Mr. Mukesh. He's been this is a plant the second day. So this is the anterior dissection of the tumor. That is, if you see, if you're seeing from the top of the abdomen, that's actually near the sacrum. You can see the right side. On the right side, you can see the blood vessels. Just a second, I think. Yeah, on the right side, you can see the iliac vessels. So this is how you dissect out the anterior part of the sacrum and the pelvis. This is the pelvic. That's iliopsoas muscle. That's the tumorous. So essentially, you're very, very precise. And here you're talking about ml of blood loss, not liters of blood loss, not even ml. Because if you lose more than like 10 ml, thing is all flooded. Essentially, you try to cauterize. That's a femoral nerve, and that's the iliac vessels on that side, on the left side of it. So you dissect out everything from front, and what you do is we place moving. So it's all they're putting into the small karla. Keep out the feeders, and we place this plastic sheet. You see the plastic sheets behind the artery. We place the plastic sheets behind the artery, so the next day when we cut either the sacrum or the pelvis, it's not going to harm in any way, and it's easier, good to go without any blood loss. This is at the end of day 2. Then day 3 we go from posterior standard approach
of Mr. Mukesh. So
standard approach.
So all well from your side.
Hypotensive anesthesia. So femoral neurovascular bundles.
Focus press
So that's how you dissect it out. So those are the nerves which you tag it out. You take out it en bloc, and this is how you compare with the 3D printed model. This 3D printed model, as Abhijit, everyone was telling, super useful in orienting ourselves in the intra-lesion, inside the surgery, intra-surgical. It's very, 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 very useful. So that's how you remove the en bloc specimen of the whole pelvis. So completely en bloc resection. This is a pathology, chondrosarcoma. This is another case of it, similar one. This is a chordoma of the sacrum. So this is in 2017. So if you see, S1 is spared. It's extremely important for us to say S1. In him, this is the robot. I'm sure most of you are aware of it, and most of your hospitals have it. The docking station. That's how you plan it from the back. We go from anteriorly on day 1, then we go posteriorly on day 2. So anteriorly same robotic.
This is having a chordoma of the sacrum.
So you place the portals, like you are removing the rectal portal section essentially, so that you have the rectal planes is what we needed. So you dissect out the left lateral pelvic wall. See, the down part is the cranial end, that's the caudal end. So you can see this, the central part, that's the whole mass of chordoma. The only problem here is the tactility is not there. So because of that issue, I think overview that comes with few surgeries you do. So here also you place, after you dissect out the front part of the chordoma, so you place the plastic sheet, or this is a Euro bag, just a Euro bag, so that when you put an osteotome back, you're not injuring any vessels. So reverse U-shaped incision. So you ligate the cord or the chorda equina, now the chorda equina here, and separate out the nerve roots. So here we could separate out the S1 nerve root very efficiently. After that, we ligated it and use a C-arm for the marking. So that is how it has come out en bloc.
Lower
Completely
cut
the chordoma.
surface, the coccyx tip was spared.
So this is the post-op, and this is the post-op day 10. So very difficult to see such outcomes in particularly sacral resections. The wound had hardly any problems. It healed very well. Because we used robot, we added a neoadjuvant radiation. This is 18 months. Now he's almost 3 years disease-free with the chordoma. Yeah. So he's having a completely, absolutely normal life. So that is what we had very minimal complications essentially related to the wound and blood loss with the use of these techniques. So essentially, you keep your mind calm and plan for the pelvic surgeries. And with the help of beautiful imaging, 3D printing, navigations, robotic, I'm sure you should be able to get a good outcomes in most pelvic surgeries. Yes, there are still a lot of challenges to be addressed. I'm sure with in the future days, it's very bright for that. And in fact, we published this in JVJS last year. And this is the whole team, what we takes it to do that. It's not me alone. It's the whole team which helps in getting this. Thank you very much for the opportunity to speak here. Thanks, Jagandeep, and thanks everyone, sir.
Thank you, sir. Excellent work. I would request Dr. Tajinder Kataria to introduce the next speaker. And I would request all the speakers that there are some questions in the chat box if they can answer them to the respective
Thank you, Dr. Pramod. I must congratulate you on this excellent series and the hard work that you've put in with a lot of dedication, because the excellent outcomes that you've shown are a message to take home that these patients are not somebody who can be left to live with the disease, but they can have a normal quality of life and be rehabilitated with good surgery, which is well planned and well thought of. Congratulations. Thank you.
Thank you, ma'am.
I would like to now invite Dr. Siddharth Laskar, our friend and professor at Department of Radiation Therapy at Tata Memorial Hospital. And he is going to address the radiation in non-appendicular Ewing sarcoma. When and how much? Over to you, Dr. Laskar.
Thank you very much, Dr. Kataria. Good to see you. Thank you, the organizers of the conclave. I need to share my screen. I hope I'm visible.
Yes, you are, and your voice is also audible. Please go ahead.
Thank you. So I'll very quickly run through the role of radiation therapy for non-appendicular Ewing sarcoma and try to dissect out the evidence of when and how much. If you look at the locations where you could see Ewing sarcomas, now 50% of them would be involving the centroaxial skeleton. That's what we would be addressing today, which includes the pelvis, the spine, ribs, jaw. And the remaining 50% generally would be the extremities, that is the appendicular skeleton. Now, if you look at the local therapies that are being used for treatment of Ewing sarcoma, as you know, the standard treatment is a combination of chemotherapy and local therapy in the form of surgery or radiation or a combination. So if you go through the large cooperative group trials, right from 73 to the recent Children's Oncology and the Euro Ewing's trial, you would notice that 40% of the patients do actually undergo surgery alone, and the remaining 60% do receive radiation therapy as either the treatment alone, the definitive treatment, or as a post-operative treatment. Now, the standard treatment, as I mentioned, is a combination of chemo, radiation therapy, and surgery. And these are the broad indications of radiation therapy as a local treatment. So it obviously is the treatment of choice for inoperable tumors where the surgical morbidity is expected to be high, and in patients where where you're expecting an intralesional excision. And the post-operative indications is a mix of the surgical margins, the pathology evaluation in the form of poor necrosis, and the soft tissue component, and so on. So let's look at the outcomes. So when you're using radiation therapy alone as a treatment, the outcomes have been inferior in the retrospective and non-randomized studies that have been published till now. Now that obviously because of the selection bias that we have, and obviously the large lesions that are not resectable undergo radiation therapy. And because of that, you would generally notice a inferior local control by about 15 to 20%. But if you look at the large databases like the ICAST 92 of 1,000 or more patients, there is not much difference in terms of the second cancers and the toxicities that you see when patients are done with surgery alone versus radiation therapy. Now, the important thing is what is the local relapse rates based on what kind of local treatment is done, whether it is radiation alone, surgery and radiation, or surgery alone, vis-a-vis the location of disease. Now, we are talking about central disease now, and you would notice that whatever treatment you do, the outcomes in central locations is slightly inferior than the outcomes that you would see in the peripheral slides, like the extremities. So although there is a benefit, the outcomes still remain inferior to what you see in the extremities. Now, that was data from the Euro Ewings, from the ICAST studies. Now, let's go and see what happens in America. The statistics are pretty similar. The moment you're dealing with pelvis and the spine, the percentage of patients that undergo surgery is much lower compared to what compared to radiation therapy. That means that radiation therapy is generally being used for patients who have poorer prognostic factors and they are inoperable, and hence the lower outcomes in terms of disease control that you see with radiation therapy. But what is noticeable and what I want to stress upon here is that outcome in these difficult locations where the margins that you get with all kinds of surgery is not as good as you would see in extremities, the best outcomes are seen with a combination of surgery and radiation therapy, and this is visible from the slides
It's
here.
going on. And you will not believe my talks.
And so moving on to some examples for chest wall PNETs, the treatment protocols remain the same. And if you look at the outcomes, again, the ICAS studies from Europe for chest wall PNETs, it's a large study here, you would notice that only about 12% of patients can receive surgery alone as the local treatment, and majority, almost 80% of patients require a combination of surgery, radiation and surgery, or radiation alone. So what I'm trying to highlight here is that in these locations, most of them would end up, almost 80% would end up having a combination of surgery and radiation or radiation alone. And the outcomes in terms of local control are slightly inferior compared to what you see in the extremities. Again, if you look at the Euroweaving trials, although at the end, the authors mentioned that in a select group of patients with small tumors, you could possibly avoid radiation. Again, if you see here, 60% of the patients did receive radiation therapy in some form, and the outcomes were not different. Now, you need to put it in the right perspective, because these patients who received radiation therapy were the ones who had large tumors, positive margins, large soft tissue component, and poor prognostic factors and poor response to chemotherapy. Despite that, the local controls with the addition of radiation therapy were more or less similar. What I'm trying to highlight here is the efficacy of radiation therapy in improving local controls, even in patients who have poor prognostic factors. This was seen in our own large series of more than 100 patients where we used post-op RT for patients with large tumors. And because of these outcomes that we have seen, where more than 80% patients end up receiving radiation, and radiation brings up the local control similar to ones with the good prognostic factors, we've made a policy in our institution that most of them we would recommend post-op adjuvant radiation therapy when you're looking at chest wall and the centroaxial skeleton. This is our outcomes. If you see here, the combination of chemo, radiation, and surgery results in the best local control. Now, another area is hemithorax radiation. Now, there are patients with chest wall tumors where you have involvement of the pleura, there is pleural effusion, and there is data from the ICAS study, the ICAS studies, that addition of radiation therapy to the hemithorax actually improves the local control and also improves survival in these patients. So the systemic relapses are reduced. So that's the role of hemithorax radiation with pleural effusion. Just moving on to the head and neck side, again, these are areas where getting margins is difficult, and hence most of the patients would end up receiving radiation therapy. This is data from AIMS. And in patients where you cannot operate, there are locations you cannot operate in the centroaxial skeleton. There are various ways you can improve the outcomes. One of them is to use therapies like proton therapy or carbon ion, and you can see the outcomes. At the end of 3 years of median follow-up, local control of 83%. It is an extremely high local control rate. And this says that possibly if you escalate the dose of radiation, the outcomes may be better. And this is our own randomized clinical trial where we try to see whether escalating dose does help. This is in publication now. It did show us that there is a significant improvement in local control and trending to be improving the overall survival if you escalate doses in Ewing sarcomas. Now, another interesting thing that was seen from the Euroweaving study is that even in patients who had good necrosis, they did seem to benefit with the post-op adjuvant RT. Now, this needs to be put in the right perspective, and the thing that I want to convey here is that it is not only necrosis, but it's a combination of necrosis and other factors that determine outcomes. Now, this is data again from the Euro Ewing, looking at pelvic Ewing sarcomas. And what I quickly want to show here is that the outcomes, 5-year local recurrence and event-free survivals, are better in patients who received post-op adjuvant radiation therapy. And it's a relatively recent publication. Our own protocols and our own outcomes, if you look at the local recurrence rates in non-metastatic operable Ewing sarcoma of the pelvis, our protocol was to use radiation therapy for large soft tissue component, closed surgical margins, or poor necrosis. And we found that patients who had radiation therapy had lesser local recurrence rates. To just summarize, radiation therapy contributes significantly to local control in Ewing sarcomas. 30% of the patients you can possibly do definitive radiation, you need definitive radiation therapy. Another 30% would benefit with post-operative adjuvant radiation therapy. This value could increase when you are dealing with non-appendicular skeleton. Dose escalation using improved techniques like protons and carbon, and conformal techniques like IMRT, which image guidance, can help escalate doses to higher level, improving local control and keeping toxicities within standard levels. Second malignancies is an issue, but as I showed you right in the beginning, it is not significantly different than the patients who were treated with surgery alone. So thank you very much, and I will be happy to take questions at the end. Thank you.
Thank you, Dr. Siddharth. That was an excellent delivery, although the time is very, very short for such an exhaustive topic. I think we'll take the questions later. And since we're already running the session late, I'd like to invite Dr. Sameer Rastogi from New Delhi for systemic treatment advances in advanced soft tissue sarcomas. And he's associate professor at Department of Medical Oncology at All India Institute of Medical Sciences. Dr. Sameer Rastogi.
Thank you, ma'am. Thanks for introduction. And I like to share my screen. Right now, I can't. Yeah. So thank you, organizers, for the opportunity. And I'll discuss systemic advances in advanced STS. So currently, soft tissue sarcoma have become extremely heterogeneous. And as you can see, it depends hugely on the histology, type of histology we are dealing with. And if you see, it could range from imatinib, pazopanib, paclitaxel, gemcitabine, ALK inhibitors, immunotherapy, everything. So I'll just cover my topic into these headings. First is therapies which are new, pazopanib, trabectedin, eribulin. Then some are histology-directed therapy, that is DFSP, ASPS, IMFT, then immunotherapy, and then anti-RK inhibitors. So this is the cartoon which shows the 3 FDA-approved therapies. This is pazopanib, acting on VEGF and PDGFR receptors, trabectedin, acting on DNA, eribulin, acting on mitotic inhibitors. So pazopanib was approved in 2012 after the dormancy of around 3 decades. It was a placebo-controlled trial, and it is approved in non-adipocytic sarcomas. Primary endpoint was PFS, progression-free survival, and see the hazard ratio. It was 0.31. That means it was significantly better than placebo. So this is our Indian data. And as you can see, the outcomes are almost same. And this is expanded cohort, 66 patients. Majority of patients in our population did well on 400 mg, and the outcomes are still good. So another therapy which was approved in 2015 was trabectedin, which was earlier marine derivative, and it is approved in L sarcomas. L sarcomas are liposarcomas or leiomyosarcomas after failure of one prior regimen. This time it was actively controlled trial, and again progression-free survival benefit was there, and it is also beneficial apart from L sarcomas in translocation-related sarcomas. And as compared to best supportive care, it has dramatic improvement in progression-free survival. So this is our data in which, as you can see, few patients did well and did not progress. So of 20 patients, we gave trabectedin till 2019. 6 patients did well for 1 year or more, and 3 of them were leiomyosarcoma, 3 were translocation-related sarcoma. So this is the first data from India for trabectedin. And the toxicities, at least there were no severe toxicities, some mild toxicities which were taken care of. and we give trabectedin with docifusor, and which is very similar to Western patients where they use disposable elastomeric pump. So patient doesn't have to stay for 24 hours in the hospital. So I just tell a case which is metastatic leiomyosarcoma, and these are the lesions which decreased after 3 cycles, and after 17 cycles, many lesions have disappeared. And the patient was still on trabectedin till that time. So it is non-cumulative drug and sometimes may give long-lasting responses. Among translocation-related sarcoma, it can give good benefit in translocation-related sarcomas like mesenchymal or extraskeletal mesenchymal myxoid chondrosarcomas. This is a patient whom we published from India. So the next drug which was approved after pazopanib and trabectedin was eribulin in 2016. It was approved for liposarcomas. And as you can see, this was active control trial compared with dacarbazine in liposarcomas and leiomyosarcomas. There was survival benefit. So which was evading in previous few trials, and based upon a subgroup analysis that it is beneficial only in liposarcomas, it was again FDA approved. So perhaps these are 3 FDA approved drugs. But sarcomas, there are 200 subtypes of sarcomas. So before sending patient that there are no other options, we must do a histology review very meticulously. So this is the newer drug, and this is the old drug which has been repurposed for angiosarcoma and vascular tumors. And we have now fair enough experience with pazopanib in vascular tumors, even in pediatric population and adult population. So this was the patient who was given propranolol, vinblastine, methotrexate based regimen and had excellent response. This is pre-therapy and it was considered palliative, and post-therapy he had excellent response. So these vascular tumors, they give excellent responses. Similarly, in angiosarcoma, propranolol based regimen, this is the pre-therapy and this is the post-therapy. Mass has almost disappeared. It was 1.5 years in metastatic angiosarcoma. However, thereafter in 2019, the patient progressed. And regarding dermatofibrosarcoma protuberans, another kind of sarcoma which is very frequently missed, molecular test not available in India. And as you can see, imatinib can be really a game changer. And the percentage response rate is 71%. So these are the data of almost 7 or 8 patients. And now we have data coming for 18 patients. The publication is in process. So now that in India this year, I think translocation testing is also available for these cancers. It's very important to pick them up and treat with imatinib because they are chemorefractory. Similarly, the IMFT, which doesn't respond to anything but crizotinib or ALK inhibitors. This is pre-crizotinib, this is post-crizotinib, lady with IMFT with lung metastasis, pleural metastasis. And recently, another drug which is FDA approved, I had not mentioned, is tazemetostat. So epithelioid sarcoma, again, extremely rare variant of sarcoma, is INI negative, smart CB1. And this tazemetostat is a selective oral inhibitor of EZH2. It was approved based on a phase 2 non-randomized trial, which is again an achievement in itself. Based upon phase 2 trials, now drugs are approved based upon molecular markers. There were 62 patients, and the dose was 800 mg twice a day. And as you can see, hardly 15% patient had response, but this was nevertheless approved because median PFS was 5 months, median OS was 19 months. And given the lack of any good drug in this sarcoma, this was approved. And we have given it to 4 or 5 patients till now. When we published one case, I'll just share with you that this was the patient who was metastatic epithelioid sarcoma post 2 lines of chemotherapy. So I think a year back or so, there was no drug. We started tazemetostat on compassionate basis. This is INI1, which is negative. And as you can see, after 3 months, the patient achieved good response, excellent response. These nodes are no longer there. So the patient maintained good response for 6 months. However, thereafter it progressed. So right now, the histology is extremely important. What about immunotherapy? As has come in almost every disease, this is yet evolving in sarcomas. In SARC-028 study, it was found there are very few patients given the rarity of sarcoma as compared to others. UPS was the undifferentiated pleomorphic sarcoma was had maximum response, 4 out of 10 patients. Alveolar soft part sarcoma is also immunotherapy sensitive with response rate of 42%. This is our data. We have given immunotherapy so far to almost 13 patients, and patients are doing well Look at the days, almost 599 days, 487 days, and median PFS, though it seems lesser, but few patients do well, and some patients are still, the disease is stable. This is one of the patient who had PD-L1 positive %. This is the disease in May 19. This is the disease in July 20. Patient is still in CR, metastatic undifferentiated pleomorphic sarcoma. Similarly, this is alveolar soft part sarcoma, nivolumab. As you can see, the lesions have almost disappeared after 22 cycles, more than 2 years. The patient is still maintaining response. So another therapy that has come is CAR T-cell therapy, or in synovial sarcoma, in which NY-ESO or MAGE4 antigen are being targeted, but this is only for patient population who is HLA-O2 positive. In India, we don't have this HLA, while in US or UK, 50% of these patients have this HLA. So unfortunately, our patients cannot get therapy unless trials are done. So, and last thing is, so this is NTRK, pen NTRK, IHC positivity. And these are the drugs which have been recently approved. So it might be only 0.1% of all the sarcomas. However, look at their response rate, which is 87% in larotrectinib and endrectinib 46%. And this is again FDA approved. So I'll thank all my team, including medical oncology, colleagues, senior residents, pathology, surgical oncology, who have been closely working with us for advanced sarcomas. And finally, this is the blueprint of the current paradigm that what needs to be followed, and what are the newer advances in soft tissue sarcoma. I think there is a lot to be there in next few years. So thank you for the opportunity. Thanks.
Thank you, sir. Thank you, Dr. Sameer, for summarizing a difficult topic quite precisely. So with this, we come to the end of this session. I think so we are already exceeding time, and we will not be able to take the questions. So I would request all the speakers to go to the chat box and answer their respective questions. So I would like Dr. J.K. Singh to invite the chairpersons for the next session on limb salvage surgery workshop.
A very good evening to all. This is Dr. Shekhar Kesri here. A very good evening to all of you, and I welcome you all in this session number 2, that is limb salvage surgery. And to chair this session, I shall request Dr. John Mukhopadhyay, sir, who is the renowned orthopedician, and currently he is the Director of Orthopedics and Trauma, Parashishimara Hospital, Patna. I'll request Dr. Sudhir Kapoor to join us.
Yes, dear, I'm already there. Can you hear me? I'm already there.
We can hear you, sir.
Hi, Sudhir. How are you doing?
I feel fine, John. So nice to see you in oncology also.
Okay, so I think we should start this session, which is going to be on limb salvage surgery. And the first speaker is going to be Dr. Jaimin Shah from Ahmedabad, and he's going to talk about Jan cell tumor, curative reconstruction in Jan cell tumor. And I'd definitely like to welcome Dr. Sudhir Kapoor, an old friend, apart from many other things. And so without much ado, we should get on with this session because we are running very late.
So thank you, sir, and Dr. Jagan and the Paras team. Can I start? Hello?
Yes, yes. So you can start. We can see your screen.
Okay.
We can hear you.
Fine. Okay, yes. Thank you, sir, Jagan, and the whole Paras team for giving me this opportunity. So today I will be speaking about curettage and reconstruction in giant cell tumor of bone. So I will be separating in 2 halves. First will be the curettage, and then will be reconstruction after the curettage. So as soon as the word curettage comes to our mind, we all take it very easy and just think that it is only simple saf safai. But mind it, when this curettage comes to giant cell tumor, it is not as simple as it, and we need to do much more than curettage. And what we want to do in giant cell tumor is an extended curettage. So what ultimately is an extended curettage is, it takes these all points to have an extended curettage and reduce the chances of recurrence. So we will see all the points one by one. And as you can see, the first point is always a wide exposure. So we as an orthopedic oncosurgeon always want a wide exposure, and it is appropriately needed in these giant cell tumors because there are nooks and corners where you can't see, and they are the predisposers of a recurrence. Traditionally, we were taught of making a window, but now the days of window are gone, and obviously we now make a big door. So it's only after you can open the door that you can enter into the house. You cannot enter into the house with a window. So always create a big door. So after creating that door, we always try to protect the surrounding structures with the spillage. And we usually do this with hydrogen soaked gauze pieces or mops, so that it helps in reducing the recurrence with the spillage, whichever is there. So after that, we remove all the extraosseous disease which is there. And this is most important step, because if this extraosseous disease is not removed, these are prone to give local recurrence, soft tissue local recurrences. So again, this large cortical door, not a window, that we usually make to enter into the disease. So after making a door, you do a simple curettage with help of these specific instruments and specific scopes, which are forward angle, backward angle, nibbler, and other sorts of instruments. So at the end of a simple curettage, you usually have this sort of cavity. And most of us stop doing curettage after this step. But as you know, the thief is still in the house and you cannot lock the door again. So you need to do more. Why? Because as you can see, after these simple curettage, these are a lot of ridges which are still left inside the disease, and the focus of the disease is still residing into these ridges. So if they are not removed, you are prone to get recurrence. So you have to remove the ridges. Like you can do with whatever you have. This is a small video in which we are using a nibbler to remove the ridges which I had shown in the previous slide. And you are trying to get a good normal contour of the inside ones. You can see the ridges are removed. So this is the most important thing. Also, we use lot of accessories, and two most important accessories that I usually use is an hydrogen peroxide solution, and along with it a pulse lavage. Hydrogen peroxide is thought to be a tumoricidal, and with the help of a pulse lavage, we use to a high pressure system so that whatever debris are there, we can remove it. So we usually use these two in an alternate in alternate wash system. So this is the way how we use an hydrogen peroxide solution. That is, after a curettage, we give a hydrogen peroxide wash alternating with a jet lavage. So again, so it's the curettage is still over? No, again, the curettage is still not over until and unless we use the Brahmastra of our extended curettage in GCT, and that all we know is a burr. So until and unless you have used a burr, you cannot complete an extended curettage in a giant cell tumor. Also, the burr has to be a specified thing. You can use a dental burr, but the RPM that we use must be on a higher node, approximately 40,000 RPM, so that you can get a good curettage of the cancellous bone and the cortical bone. So this is the burr that we typically use it. Now, as the previously also we had heard the speakers telling about the adjuvants. So there are a lot of adjuvants which are available, such as phenol, alcohol, argon, and cryotherapy. Each of these adjuvants has their pros and cons. We usually don't use any of these adjuvants. We usually rely on getting an extended curettage with the help of a burr, but you can use it with your own peril. So basically, what my talk was to highlight the advantage of what is an extended curettage, and this slide highlights that thing, that when you do a simple curettage, you will just do a scooping of that disease, but with the help of an extended curettage, you can get a 1 or 2 millimeter more disease clearance, and this is the most important thing which helps in preventing recurrences in giant cell tumor. So again, this extended curettage is very much important. So I will just show a simple video of how to do an extended curettage. This is a distal femur giant cell tumor. Pardon me, I don't have a pre-op X-ray, but this is how we do an curettage. So as you can see, we are removing the extra osseous disease which is there. The wall of the femoral cortex is thinned out, and we are trying to take it off along in a single piece. So as I told earlier, this is most important because these are the soft tissues. If left as alone, they are prone to give a soft tissue recurrence. So always try to remove it in a single piece. So as soon as you remove that thin shell with the soft tissue, you have to do a simple curettage with whatever you can. In this case, we are using a spoon to remove the gross disease which is there inside the disease. And then you can use simple scoops or nibbler to remove the gross disease. So this is a typical appearance of a giant cell tumor, friable tissue which is there inside the cavity, and which you have to remove with the help of a scoop and nibbler or whatever you want. So after the simple curettage, you can see these ridges which are left. So if you stop at this point, you are liable to get a recurrence. And as I have told earlier in my talk, you need to remove these ridges. So what we do is, after this step, we do a hydrogen and a pulse lavage alternate wash, so that we can get a clear look at the ridges. And this is the clear cut ridges which are seen. So as I have told earlier, we need to remove these ridges, and this is the high revolution burr system that we usually use. And as you can see, the ridges which are there, they are clearly removed with the help of this burr, and it helps in removing the residual disease. So you then burr the cortices of the cavity, the end sides of the cavity, just to have a disease, just to have more clearance of the disease. So after doing this vigorous, and you can see how vigorous we are. So we are left with such sort of cavity. So one question remains is, how long do you curate? So what we usually note is the paprika sign. As you can see, there is a fresh bleeding from the remaining cancellous bone, and we usually do burring up till this part. So this helps us in preventing recurrence. And as an adjuvant, we usually use this high-end electric cautery spray mode. I don't know what helps this, but we usually follow this and just burr the whole walls of the remaining cavity. And after this, you can fill the cavity with whatever. In this case, we had used a cement to fill that cavity. So basically, again, this is one more video that I want to show you is, so this is another case. So after curettage, many times you get this soft ping pong type of soft tissue which is left. So you cannot use your burr in these soft tissues. So it is very important that you remove these soft tissues so to prevent recurrences. So this is also one most important step while doing an extended curettage in GCT. So now I will come to the second part, is the reconstruction after the curettage. Is with what do you want to fill the defect? So basically, we have two main things by which you can fill the defect. One is the cement and other is the bone graft. That bone graft can be an allograft, autograft, or a synthetic bone graft. It depends on your personal choice. And obviously, you can use both of them. The popular technique is known as the sandwich technique. So this is the classical slide from a TMH presentation, where whenever there is a very thin subchondral bone left, you can do a sandwich technique in which the cement and the articular cartilage is interposed with a bone graft. So the idea was that cement might cause damage to articular cartilage, but the recent papers have shown that cement does not interfere with articular cartilage. So as a general rule, if the cartilage subchondral bone is less than 5 mm, you can use a sandwich technique, and if it's more than 5 mm, then you can use cement or bone graft. Now recently, we have usually don't use the sandwich technique more, and we are more prone on filling the cavity only with either cement. So next question comes, when to do a fixation. So it's an SOS thing, and it's totally an intraoperative decision, as told by sir previously, that if you feel that the stability of the bone is compromised after doing an curettage, then you need to fix that bone to prevent a iatrogenic fracture or a pathological fracture later on. what I usually follow is if the more than 50% of condyle is involved, and more so in case of distal femur, I usually do a provisional fixation along with the filling of the defect with a plate. So how to put in a cement and plate both? So it can be done in many ways. First way is just you put a plate, do a curettage, put a plate, and then fill the defect with the cement. This is the another way in which after doing a curettage, you do a provisional fixation first. Just slide the plate up, fill the cavity with the cement, rotate the plate again, and then fix with the screws. So this is one of the other technique by which you can use cement and plate both. So, just to highlight some of the cases. So this was a case of a proximal femur giant cell tumor where an extended curettage anterior approach was done and the cavity was filled with 2 fibula strut grafts. Again, fixation was not deemed necessary and patient went on to heal very well. So this is another case of a proximal tibia giant cell tumor. And here, as you can see, more than 50% of the tibial condyle is involved. So we had to put an additional plate for a fixation. And these are the cases where you need to do something more. These are another case of a distal femur giant cell tumor where a biological fixation was done after doing an extended curettage. You can see only 2 fibula strut grafts were kept, and after 5 years you can see how beautifully the fibulas had remodeled and there was no any sign of recurrence. So again, what to use to fill the defect, it's again a personal thing. I don't think any papers are there which recommend one thing over other. So there are proponents of bone grafters and there are proponents of cementers. So you have to decide per case by case basis. And this is one of the last case where this was a GCT of distal femur where curettage and bone grafting was done. There was a recurrence, and as you can see again, more than 50% of the condyle was involved. And so we had to do an extended curettage, cementing, and a plate was kept to just prevent a pathological fracture later on. So again, when you don't have any wall after curettage or you predispose that this thing is not curatable, so this topic has been already covered previously, that when to curate or when to reconstruct. So when these are the scenarios, then you have to do a resection, and reconstruction after that resection, it's a totally different thing, and I might not be able to cover that part. So just to summarize, take-home message is always biopsy. All lytic lesions are not GCTs. If it's a GCT, always try to do an extended curettage. You can try to use adjuvants. Always do a proper reconstruction if needed. And the last line is always whatever is needed in bone tumor cases is you do counseling properly regarding recurrence and other things. Thank you.
Thank you, Jamin. That was well sort of planned out and actually kept on time, which is probably one of the first today. So,
thank you. Thank you.
I think I will ask Dr. Sudhir Kapoor to invite the next speaker.
I think he has covered most of the things. What I was wondering was that we should be using whatever is easily available. I think we have shown most of the things. But what is his take on using phenol? Phenol is one thing which is easily available in all the operation theaters and the laboratories in the hospital. I don't think we should leave anything which can be of help for a final good result. He has shown most of the things, but this is a small suggestion that besides extended curettage, besides hydrogen peroxide, besides pulse lavage, it is still. Let us add some amount of phenol also. Whatever little chances are there which are reduced, which can be reduced by phenol, is for the benefit of the patient.
You do whatever is necessary, but I think today with the high-speed bursts, the role of these adjuvants is actually gone down compared to what they used to be earlier. But certainly, if you feel you think you will.
It is just a small point. Let us always know that what are the other things which are available. And this is one thing which is very easily available.
Absolutely.
Yes.
Now I can ask Dr. Shriman from Bengaluru. He is a senior surgeon, oncosurgeon from Bengaluru, and he is talking about the glamorous subject of mega process, which has been used to attract a lot of juniors. It still remains glamorous, and I'm absolutely sure that he will do a fantastic job with this talk.
Thank you so much, sir.
Well done, Dr. Shekar.
Hello.
Yes, you are audible.
Yes, sir. Thank you. So
Yes.
I'll just
share your screen.
I'm unable to share because somebody's saying that other participant is sharing. Can you just help me?
Okay, I think now you should be able to. Yeah.
Now I should be able to. So that should not be a problem. Let me just see which one was that. 1 second. One second. I think this is a small hiccup here.
Can the technical people please help him?
Yeah, yeah. No, I think that should be fine. So probably
Okay.
just, yeah. So 1 second.
There is a share screen button.
Yeah. No, I think there was. Yeah, is my screen shared now? Is it visible?
Now it is. Yeah.
Yeah. So
yeah, good.
Thank you so much for Dr. Jagandeep and all the faculty of Paras Hospitals for inviting me for this small talk. So what I'll be doing today is I'll be sharing a bit of limb salvage surgery. So I've been given the topic of metaprosthetic reconstruction. So I'm from Manipal Hospitals in Bengaluru. So I'm part of the Manipal Comprehensive Cancer Center. So greetings from my institute also, because most of my work over the last 6 years has been in this place itself. So just to start across, we do know that in the principles of limb salvage.
Dr. Sriman, excuse me, can you put it on full screen mode? It is coming on presenter's view mode.
Let me just try it again over there. I think there is some small issue. Let me just try it out. Yes, so.
If I can help you, I think you are presenting from a Mac. Is that right?
No, sir. I'm not presenting from Mac. I'm actually presenting from this one, the PC itself. So I think there's some small hiccup here. Why?
There's one presenter view and one there is the audience view.
Yes. So what I'll do is I'll just try to change that. Yeah.
Right.
I think now is it visible, sir?
You were still on presenter's view, unfortunately. So I think what you need to do is probably close it and open it again, and then share your screen again.
Yeah, surprising. I don't know. Never had this hiccup before. So
happens sometimes when you least expect it.
So let me just try that again over there.
Just switch it off, switch it on again, and go to directly to.
Okay. Yeah, now it's visible, sir. Full screen.
Yeah, looks like now you're still on that.
Still on that, huh? I'm surprised.
Or just go ahead. It doesn't matter if the people see your next slide. If you don't mind.
Sir, can we share from our side?
No. I think I should be able to do that. Now is it visible?
Yeah, it is visible, but ये वही presenter view में ही show रहा है.
I'm showing presenter's view, but you could carry on with that. It's not such a big deal.
I think I'll just shift that off and I'll just put it across. So just give me a minute with that. Let me just. Sorry about the hold. Let me just do it right here now. Okay, so. Extremely sorry about this hiccup. So I really am unable to, get the presentation out for some reason. Yes.
What you should do is shut your presentation.
Yes.
Open it again. Yeah. Just do that. You'll be okay.
Yeah, I'll just do that.
Minimize it and then go to share screen.
Fair enough. I think even though the meeting went for it. Would you be kind enough to just run the presentation from your end, because I think there is some difficulty here.
Yeah. So can we do that?
Yeah, we can do that, sir. That's not an issue at all.
Okay.
Yeah, great. Thank you. Extremely sorry. Sorry for the hiccup part over there. The thing is, you can run the slides down. So I should give you the indication for the slide sharing, right? Like, so could you go to the next slide? Yeah. So, you know, we are definitely faced with a large volume burden in India per se. So whenever we look at principles of limb salvage, we try to see, can we get the acceptable margin first oncologically? That's the most important prerequisite. And next, we try to see, can we attain or obtain an acceptable function part over there? So these are the two components which help us try to do a limb salvage. And can you please go to the next slide? Yeah, the next one, please. Yeah, so in these, my topic is for tumor megaprosthesis. As you know, there's a plethora of options nowadays for extremity sarcomas. And in that tumor process, we see that most often we use a non-expandable versions for the adults and even up to kids between 12 to 13 years of age also. And when we go for expandable prosthesis, we try to use the invasive ones and the non-invasive ones. Non-invasive ones being the magnetic controlled ones by a few companies abroad. And lastly, intercalary prosthesis, which in India, it's not in much of a vogue. The next one, please. Yeah. So again, no surgery is you know, a complete or a success without a preoperative planning. As I would put across by one of the fictional characters in the same, that if we fail to plan, we are actually planning to fail. And whatever simple and however simple or straightforward the case might be, planning keeps a big role in trying to get the best of the results, as even in a regular or a routine tumor megaprosthesis, or even a complex prosthetic and you know, a graft prosthetic or in a pelvic reconstruction also. The next one, please. Yeah. So yes, with this slide, I would say we have come to an age where we need to customize for every patient. It's like not tumor megaprosthesis or something else is not the mantra for all. The next one. Yeah. So, and when we look at how we achieve it, we are not, you know, going through an easy job. It's actually walking on a tightrope because we have so many issues to deal with. As you can see on the right-hand side, the challenges or the complications or whatever hurdles and obstacles which we do face across when we try to treat these patients. The next slide. So, why tumor endoprosthesis? As you can see, they do allow us, you know, the benefit of giving an immediate weight-bearing aspect for the patient. We do have modular and custom solutions. Longevity is one issue. That's one of the reasons why we hold back on the tumor endoprosthesis nowadays, and we have much more options also coming up. But the range they say is anywhere between 10 to 20, 25 years, depending on the type of the implant we use and the amount of bone we resect also. And unfortunately, they do require revision surgery. So we have to have a lot of forethought when we try to use these prostheses. The next one. Yeah. So to start with, one of the cases, one of the earliest cases for me, and what you know is still lasting, and we know that it's going to last, is that a conventional distal femur osteosarcoma. As you can see, the biopsy scar is on the medial side, and this is one of the most preferred biopsy scars, medial, anteromedial, or the lateral approach, depending on what type of locking mechanism your prosthesis has. As you can see, we've used a fixed hinge tumor prosthesis. The resection has been done with a 3 centimeters of a margin. You can see that the resection margins are adequate. So oncologically, we are good to go. And with this, the wide enough exposure, you can see the prosthesis on the lateral picture view with a good knee bending. And the addition in this was that we used something called as a bone graft necklace from the tibial cut, which was publicized a lot by Dr. Shekhar Kumta from Hong Kong and others also. And we've got a pretty good extracortical bone bridging. What this extracortical bone bridging helps us with the patient is that it can reduce the chance of implant failure or loosening across the femoral stem or the tibial stem, whichever place we would go across. And I guess that's some you know, small addition or a forward which we would take probably with the tumor prosthesis. And the function is pretty good at 6 years. And in fact, he's driving a cab right now and is having a livelihood. The next one, please. Similar situations, conventional sarcomas, the function is good and they do pretty well. As I said, the longer the resection, the lesser the outcome. So, in distal femurs, we don't seem to find some sort of extensor lags, which see more often in proximal tibias, but they tend to do really well. What we do make sure that is we ask them to avoid squatting or sitting cross-legged, which they can do, but we would want them to avoid as to, compared to conventional arthroplasties. Next one. Yeah. So in certain situations, I would say probably in all of the situations, if I was given the option, I would definitely try to use a rotating platform mechanism. This rotating platform mechanism tries to mimic the normal knee rotations of a basic 2 to 3 degrees. And definitely this has shown to have a longer, outcomes and longer survival rates compared to fixed hinge processes, which were 20, 30 years old of technology. Whereas these are the ones which I would probably say, which we can use. So again, in India, we can use cemented versions of rotating platforms and even uncemented ones. In youngsters, I would prefer to use an uncemented version. In this situation, it was a 13-year-old girl who had a pretty good treatment response, and we went ahead with a rotating platform, and at 1.5 years of follow-up, you can see that she's doing pretty well too. Next one. Yeah. Sometimes, we are faced with certain challenges. We have patients coming with biopsies in odd areas. So this is where they've gone right through the quadriceps, which is an absolute no, because if the involvement is quite high, it's a pretty big open biopsy, we often tend to land up doing an amputation. Why? Because if you resect the quadriceps in a distal femur, we definitely are not going to land up with a good function for the patient. Maybe we're going to have a patient consenting for tumor processes and not walking properly, which he would say, I wouldn't mind. But at the same time, often larger contaminations would lead to local recurrences. As we know in literature, open biopsies and sarcomas are the highest risk for local recurrences. And when we get those patients, our heart's literally in our mouth, and we try to make sure that we go as wide as possible. In this patient, somehow we could save around probably 30% of his quadriceps. But as you can see, his function is pretty good with very good rehab. He still has to improve, but at 3 years, I think he's doing pretty well. The next one. Yeah, and these are oops again. So you have a pathological fracture. A simple needle biopsy would have been comfortable, but again, you could see in the lower bottom area as to the amount of open biopsy which was done, and my marking of the amount of excision, which nearly took out 50 to 60% of the quadriceps and the intermediate musculature, which makes it hard for the patient to rehabilitate. I could do a limb salvage here, and the good thing was the patient had a very good response post chemotherapy, 100% necrosis, which is not common in pathological fractures. So we could actually go with a limb salvage. The child, you could see, is actually walking with a knee brace, and I'm not sure how long we're going to have the knee brace on, because getting those quadriceps rebuilt and with good physiotherapy might be early or might take long also. So he has around 90 degrees of bending, but since he's unable to lock, and with the rotating platform, I would prefer to have a knee brace for another couple of months and try to see how he rehabilitates. So the next one, please. And yes, challenges are not less again over there. I'd like to share another interesting case where I said probably I would do an amputation. I said, no, I don't think we'll be able to do a limb salvage. And this girl actually presented to me with a FFD of 90 degrees with such a huge tumor mass. Surprisingly, again, she responded, and she was motivated. So went in, did the resection, put in a free ALT flap to close the medial center defect, because the skin itself was not that great. And at 1.5 years, she's actually doing pretty well, and she's again aspiring to become a doctor. So we're keeping our fingers crossed, because the tumor volume is pretty high, but the necrosis again was 99% in her. So tumor processes does help in a lot of situations. Again, to go on a different mindset, I have a patient here who's probably, in a bit of a poor prognosticating indicator in some factors, and a good prognosticating indicators in some factors. So my aim is, can I salvage the limb? Even if there is an extensor lag, can I make sure the patient can walk and have a good quality of life? So my aim was that. But now when I can see the patient has only 15 degrees of lag, unfortunately, I don't have the photo here, and that's her actually standing next to me just before she flew back to her hometown. So yes, tumor processes can be used in certain situations where we feel that we need to give the good quality of life also, and not in all absolute curative attempts also at the same time, which is a bit controversial, but I would say probably it would definitely help them out. The next one, please. Yeah. Tibia, again, is a totally different perspective. One of the challenging scenarios, big tumors, big resections, high failure rates in tibia. And as far as I would say, I have seen anywhere between 20 to 30 degrees of extensor lag in majority of the tibial prosthesis patients which we've operated. So what I have done is I've moved on to graft prosthetic composite reconstructions nowadays, so that we give them a very good functional outcome and a longevity also. Unfortunately, this patient had an infection and I had to revise it. Next one, please. So rotating platform also does really help these patients do very well in proximal tibias. I've had a late adult who's doing pretty well with an cemented tumor prosthesis. So yes, even he also has, even the best of the locking mechanisms of the quadriceps, has a 10 degrees of extensor lag. The next one, please. Could you go to the next one? Yeah, so certain situations we need expandable prosthesis. This is a child who's had a custom invasive expandable prosthesis by one of our Indian companies, and he's doing pretty well at 3 years of follow-up. We've had a bit more lengthening than this also. And the next slide. Yeah. In other situations, we can use these non-invasive magnetic expandable prostheses where the child just has to come down, put his leg in a coil, and he has a good expansion. So yes, both options are available, but the magnetic ones do cost a bomb and they do cost a lot more. So we are definitely innovating different ways to try to help pediatric or adolescent populations, where I would probably say the range of age would be between 8 to 12. So beyond 12, we would use a conventional adult one, depending on the height which they've achieved. And less than 8, I would say probably we would offer a rotation plasty for all practical reasons expected to the growth of the child also. The next one. So proximal femurs, again, they also do well with prosthesis, and they have a very good outcome. Bipolar is better than a THR, I would say. And this is an uncemented version where they're doing pretty well. Next one. Yeah, and proximal humerus also, they do pretty well. Unfortunately, axillary nerve is resected, so they have only elbow and hand and wrist functions. Could you please go to the next one? Yeah, so I would like to conclude saying that there are a few advantages. They're modular, immediate weight bearing is available, early rehabilitation, and QOL is similar or better than amputations. Disadvantages, yes, we do have a long way to go in India. Limited longevity, rotating is better than fixed hinge around the knee. They often require revision surgery, and all the risks and complications of tumor processes are seen, and we are still fighting our way to try to get out of these instances. Could you go to the next slide, please? Yeah, so my thanks to Paras Conclave and the organizing team for giving me this opportunity. Apologies for the hiccup. Hope you have a good session. Thank you so much.
Thank you, Dr. Srimant, for a wonderful presentation. I would request Dr. Sudhir Kapoor to introduce the next speaker. Rather, I am the next speaker.
I mean, I think I can't start my video. Video has been blocked for me. Anyhow, I mean, there is not Jagandeep Singh is there. He from near Chandigarh. He'll be talking about his experience of limb salvage in malignant bone tumors. Let us start here.
Thank you very much, sir. I cannot share my screen. Surbhi, would you please put me on share mode? Yeah.
Me? Okay.
Can you see my screen now?
Now it is visible. Yes, it is visible.
Yes, sir.
So after the glamorous world of orthopedic oncosurgery, as shown by Dr. Srimant, we move into the non-glamorous part of biological reconstructions. Rather, form of biological reconstructions I'll be talking about. So my topic is on recycling of tumor-bearing autografts in limb salvage surgery in bone sarcomas. So as we all know, limb salvage surgeries, they consist of two parts. First is obviously the resection part with wide margins, which can either be in the form of an osteoarticular resection or an intercalary resection. And second part is the reconstruction part, of which we are talking about. So either it can be done in the form of non-biological reconstruction, in the form of a tumor prosthesis, a nail cement spacer, biological reconstruction in the form of a vascularized fibula, recycled autograft, about which I'll be talking, or it can be in the form of allografts, or it can be combined in the form of allograft processes composite. So talking about recycled autograft, they have some specific advantages over other forms of reconstruction, such as they provide an anatomically sized matched graft, they restore the bone stock, they're inexpensive, there is no need for a bone bank. Limitation is that it is only possible in cases where there is a good response to chemotherapy, or rather there is minimal bone destruction and there is restoration of bone due to good response to chemotherapy. So the various methods of recycling these tumor-bearing autografts once we have resected them, the commonly used one is the extracorporeal radiotherapy, also known as ECRT. So for that, we require a radiation oncology setup, which most of the cancer centers nowadays are having. The disadvantage is obviously the bone needs to be sent outside the OT to the radiation facility, where it is recycled and sent back to the OT. A method which is commonly employed now is cryosterilization with the help of liquid nitrogen. The advantages with this is that there is no denaturation of the bone collagen, and there are better biomechanical and osteoconductive properties. Autoclaving and pasteurization has also been used in the past. So I'll be mainly highlighting the role of ECRT and liquid nitrogen as far as recycling of tumor-bearing autograft is concerned. So this was a 12-year-old boy biopsy-proven case of osteosarcoma in the proximal tibia. Post-neoadjuvant chemotherapy, as we can see on the MRI, that biological reconstruction in the form of an intergallery resection and biological reconstruction was possible, since the disease was a little far away from the articular cartilage and we could get safe margins. So as was done in this case. So once the bone is resected out, it is wrapped in sterile sheets and it is sent in a sterile container to the radiation facility, where about 50 gray single fraction 30 minutes radiation is applied to the tumor bearing autograft. It is received back in the OT and it is fixed with, as in this case, with locking plates and screws, and also the autograft has been filled with bone granules just to increase the biomechanical strength of the bone. And this is at 3 months that the patient is having good knee function, ankle function, and was able to walk. So another case is of a 48-year-old female. So in this particular female, we decided to use chemotherapy. The radiograph showed aggressive looking lesion. Apologies, I don't have the radiographs. So in the MRI, we can see on the T1 sequence that there is a hypointense lesion in the diaphyseal part of the humerus. In the T2 contrast images, we can see that there is extensive soft tissue extension, peritumoral edema, the relationship to the neurovascular bundle. Whole body PET CT revealed it to be the only solitary lesion. We did a bone biopsy, as has to be done. So it came out to be Ewing sarcoma. So discussed in the multidisciplinary tumor board, planned to proceed with neoadjuvant chemotherapy. 4 cycles of IE protocol was given, followed by limb salvage surgery. So this is the post-neoadjuvant chemotherapy MRI. As we can see that the peritumoral edema has completely subsided. We can clearly make out the extent of the lesion. We planned our margins, and this is the post-chemotherapy X-ray, which we can see that the bone has had a good osseous response, and biological in the form of cryosterilization was feasible in this case. So cryosterilization has mainly been propagated by the Japanese, mainly by Socha et al. And this was one of the landmark papers in JBGS in 2005, which highlighted the role of cryosterilization and how exactly this technique has to be done. So after the surgical planning, we can see that the neurovascular bundle, it has been safely preserved. And intraoperatively, since we are not sending the final dissected specimen for the final histopathological analysis, we do need to send frozen sections from our proximal osteotomy site, the distal osteotomy site, and from wherever we feel that the soft tissue margins are close. All the intraoperative frozen came out to be negative for malignancy. This is the resected specimen. So within the OT itself, once we have resected out the specimen, it is taken on another sterile trolley and the soft tissues are stripped off. The canal is reamed, and whatever soft tissues and the medullary canal contents we obtain, they can be sent for histopathological analysis in order to know the necrosis rate, which can tell us about the adjuvant chemotherapy which needs to be given. A vicryl thread, we make multiple drill holes, and one of the drill hole is used to tie a vicryl thread to one end of the resected specimen. Liquid nitrogen is poured into a sterile container, and at minus 196 degrees Celsius, the bone is cryosterilized for about 20 minutes, thawed for about 15 minutes, and then put in distilled water or vancomycin mixed saline for about 10 minutes and reimplanted back into the defect and fixed with plates and screws, as we can see in this. So the distal osteotomy site, it has been augmented with bone granules. This is at 1 month follow-up. This is at 4 months. We can see some bridging callus already at the end of 4 months across the proximal osteotomy site. So usually in these kind of reconstruction methods, the proximal osteotomy site or the metaphyseal osteotomy sites is not a problem. The bone usually unites very well. It is usually the distal osteotomy site or the diaphyseal osteotomy site which have a tendency to go into non-union. And overzealous physiotherapy by this very patient, and she was not following some instructions. We landed up in this situation. We repeated a PET which showed that there was no disease, and we planned to do an augmentation plating and Elicrest bone grafting and augmented it with a plate. Once the patient was over with the adjuvant chemotherapy, because we didn't want to put any delay in the or a gap in the adjuvant chemotherapy, and the bone went on to heal nicely. And this is a 2-year follow-up. The patient is having very good elbow, shoulder function. So this is the advantage we can get with biological reconstructions as compared to intercalary endoprosthesis or tumor prosthesis. There are some concerns regarding recycled autograft as far as risk of local recurrence within the reimplanted bone is concerned and graft absorption. So actually this landmark paper by Sucha et al., it dismissed all these concerns which are there with recycled autografts. In their series of 28 patients, they only had 2 local recurrences. Bony union was achieved at a mean of 6.7 months, and a 2-year overall survival was almost to the tune of 75%, 5-year overall survival to the tune of 65%. So while my time with me, when I was in Government Medical College with Professor Sudhir Garg, we did our own institutional review. Dr. Sudhir did quite many patients with recycled autograft technique using liquid nitrogen. So we published our own paper in the Indian Journal of Orthopedics. We had a series of about 10 patients in which there was no local recurrence reported at the end of 2 years, and the mean time to union was around 5.2 months. Another additional advantage which has been highlighted, which we get with cryosterilization, is the concept of cryoimmunology, apart from the superior bone properties we get over ECRT. So cryoimmunology basically means that the frozen autograft release certain tissue proteins which have certain antigenic properties which initiate an immune response against the micrometastasis, which decreases the chances not only of the local recurrence, but even of the distant recurrence. But although the evidence at present is weak to support the concept of cryoimmunology. So these are some cases from that study which we did. So a large proximal humerus osteosarcoma, post-chemotherapy, we can see that it has nicely ossified. We did a recycled autograft. Another case of proximal humerus, proximal femur, shaft femur. So it is preferable to use biological reconstruction methods wherever an intercalary resection is performed. The function and the outcome are much superior. These are some cases from the same series, and this is a 6-year follow-up. Distal fibula. So it has been used even in sarcomas of the pelvis. So this is from a study by Dr. Sucha that they have used even in pelvic resections. Once it has been resected out, it is recycled with liquid nitrogen and reimplanted again. And this is a kind of prosthesis autograft composite. So non-union, yes, as I already highlighted, is a concern with recycled autograft, be it ECRT or with liquid nitrogen, although it is less with cryosterilization. And there are few techniques how to circumvent the same. One is a use of Kapana construct technique, which has been described in allografts, can also be used in frozen or ECRT autograft, or the use of a single osteotomy known as the pedicle freezing method. So this is the Kapana construct, in which basically free fibrillar graft is obtained, vascularized fibrillar graft, and a trough is created through which the vessels are anastomosed to the main end to side anastomosis is done depending upon the site where it has been used, and it is sandwiched within the frozen autograft or the allograft. So especially in the femur side, it gives superior union outcomes as compared to using alone a frozen autograft. So pedicle freezing method is where we only make one osteotomy, and usually we try to make it at the metaphyseal side. The limb, it is rotated by about 360 degree into the liquid nitrogen, and by this way we are only creating one osteotomy site, which gives superior union rates. So the advantages of pedicle freezing method over a free freezing method is the anatomic continuity of the vessels, which is preserved, the blood flow which flows immediately from the distal to the frozen fragment, and osteogenic cells which are preserved. And this is the histological examination of a frozen autograft, where we can see that there is almost 99% viability of the bone, and there is remodeling of the bone with osteoblasts and osteoclasts, and there are even blood vessels in the subchondral bone. So I would like to conclude by saying that limb salvage surgery utilizing recycled autografts does make sense, especially when we are getting superior survival rates and whenever we are contemplating that there is a good response to chemotherapy, and wherever it is feasible, biological reconstruction methods, they give superior functional results over endoprosthetic or artificial methods of reconstruction. And in the future too, we think that there'll be more advances in biological reconstructions as compared to advancements in bioengineering. Thank you very much.
I think Jagandeep has very nicely shown good results with his technique. I understand that we have two experts also. Dr. Sagar is there and Dr. Parikh is there. Dr. Sagar from Jalandhar, all of us know him, and Dr. Parikh from Mumbai. Would they like to give their comments?
Yeah. Hi, good evening, Dr. Sudhir and the faculty. First, can you hear me?
Yes, we can hear you.
Yeah. Thank you very much for letting me participate in this conclave. And just a small comment, I mean, both the speakers, especially the EPR and Jagandeep talking about the cryotherapy, they have nicely summarized the topic. And what Shrimant was talking about, basically, there are certain issues with the mega processes. Like, for example, there is a concern for the life of the mega processes. We usually, because we have a fixed hinge mega process usually which are available now, the rotating is also coming up and the incidence of aseptic loosening is going down. There are issues with the extracorporeal bone bridging, which was talked about which actually has cut down the incidence of aseptic loosening as well, because aseptic loosening is a very big concern. Infection is getting controlled with better techniques, better duration of the surgeries, better implants. So the infection control is also is far better than what it was, like 30%. Now it's coming down to almost 8 to 10% cases. The results of mega processes per se, we know that distal femur does better than proximal tibia, and even the proximal femur does better. It also shows good results. We have now for children coming up the expandable and the intercalary processes with, but given, having said all about this non-biological reconstructions, the word of caution which was talked about, just touched by both the speakers, the nail and plate spacers, I have strong concern. There's a high rate of failure with these kind of non-biological nail plate spacer reconstruction. They usually fail. So we have to be very, very cautious when we're giving these non-biological reconstruction of options to our patients, that a proper counseling is done, that there is a risk of revision down the 5 years, 10 years down the line, and henceforth the cost of the revision surgeries also go very high, and which in Indian scenario is very, very important aspect. Dr. Jagandeep very nicely put in the biological reconstructions. And as over the years, since I've been doing these EPRs for more than now almost 20 years, and I've revised many of my own mega processes. And trust me, even my inclination is also much more for these biological reconstructions. There's no mismatch, much more economical, and it's a relatively it's the patient's own bone ultimately. When once incorporated, the revision rate, reoperation rate is much less, as long as we're taking care of certain issues regarding the non-union. The ECRT and both the cryosterilization, they have a promising role, and especially for cryosurgery, the pedicle freezing, which if possible, if intracalary section for some reason we can avoid and do something kind of pedicle freezing, given depending upon the location of the tumor, has a much lower issues of the union. I think that's it. Anything else, Dr. Mitchell, you want to add?
No, sir. So you've rightly, summarized everything, the advantages, the disadvantages, the complications, and how we are getting around it, and giving better outcomes to all our patients. So very comprehensively put, limb salvage surgeries, all aspects of it, right from basic evaluation to the complex reconstructions and managing some of the basic complications. So I mean, it was a very good session, and I hope everybody took the take-home message very perfectly.
I'd like to add one small comment. I think how many of us have noted the natural curve of a oncosurgeon, which Dr. Saggar, inadvertently, without actually meaning it, he just showed you. Initially, all the oncosurgeons are drawn towards oncosurgery because of the somewhat grammar attached with the mega processes. Once you encounter your failures, gradually you tend to shift towards biological methods. This has happened with all of us, happened including me. But let us understand that we have to maintain a certain balance between the use of mega processes, the indications. Over years, you learn with experience that what patients will give you the best results. I think all of us know that lower end of the femur is the best possible site for a mega process, in particular in a youngish fellow. And gradually we should limit and identify the right cases for which a mega process is indicated. Otherwise, in general, as Dr. Saggar pointed out, over a period of time, I think biological methods are better, longer lasting, and they are more economical. This is what I would like to say. This is the natural progression of a curve of an orthopedic surgeon who's indulging into oncosurgery.
Yes, thank you, Dr. Sudhir. I think it's very well taken. Last of all, which I would like to just last comment, I mean, which Dr. Shriman did talk about in a very younger children, less than 7-8 years old. I mean, all those amputations and rotational plasties also have a role in Indian scenario. Anytime we get a chance, please do make a video of your patients, because it may help in convincing the next patient. So they also have a clear-cut role with a better quality of life in these younger patients while performing limb salvage surgeries. Thank you.
Point well taken, sir. Reasonably good session, and the audience, whatever audience was there, must have learned few things from this with the talk. And I think I must congratulate with my co-chairperson, Dr. John, all the speakers, and of course the organizers for having a very extensive program. I think we can call an end to this session unless Dr. John wants to add something.
So Dr. John had some urgent piece of work, so he had to leave. So thank you very much, sir. Thank you, the chairperson, speakers, and experts, and all the delegates for joining this session. And with this, we come to the end of this bone and soft tissue tumor session, and we can move on to the next session on radiation oncology workshop. So for this, I would like to invite the chairpersons, Dr. Amal Roy Chaudhary. He is a director radiation oncology, at Fortis Memorial Research Institute, Gurugram. And Dr. Pritanjali Singh is additional professor and head of Department of Radiation Oncology at AIIMS Patna. I welcome you, sir, and I welcome you, ma'am. I would request Dr. Chaudhary to kindly introduce the speaker and start with the session.
Sir, Dr. Amal is not here.
Okay, Dr. Pritanjali Singh, has she joined?
Yeah, yes.
So, very good evening, everybody. We have come to the end of the sessions, and to top it up, we have a very interesting topic on hippocampal contouring, the tips and the tricks. And we have with us a very eminent speaker, Dr. Rahul Krishnanarthi, who is Associate Professor in the Department of Radiation Oncology of the Tata Memorial Center in Mumbai. May I ask him to start his talk?
Thank you, Dr. Pritanjali, for your kind introduction. And it's a very great program lineup today from the Paras Cancer Conclave, and I would like to congratulate them for this. And thank you for having me here today. So I'm not able to share my screen. Can you allow me to share the screen so that I can show my slides? Yes.
Now you can share.
Yeah, thank you. Okay, perfect. Yeah, so as you know, it's a workshop kind of a thing, but it's a virtual thing. So I'll try to show you each slice by slice as per the RTOG, how to contour the hippocampus for radiation in the brain. And in the end, we can just look at some tips and tricks that I use in my clinic, even in my initial days, how to be sure what I'm drawing or contouring is hippocampus. And later on now, when I review my students' contours, then also I use the same trick. Now, coming to what are the, why we need to talk about hippocampus is basically we're looking to preserve the neurocognition. And whatever little or more we understand as of today, there are several organs which may affect neurocognition as such. Apart from the usual temporal lobe, it is amygdala, right, the hippocampus bilaterally, and the frontal lobe pathway as well. And certain textbooks even recommend posterior fossa, some corticospinal tracts also, which relay and play an important role in neurocognition. But still date, whatever we understand, the maximum or the most important critical structure right now, which is addressable, is hippocampi. And that's why probably what we look at is contouring hippocampus today. And what the standard atlas, which is used internationally, is basically from RTOG, developed from the BrainMed study that we have is RTOG 0933. Now, which image to use to contour is basically MR. And MR also, it is necessary to have T1 plain image or T1 contrast image. In T2, you would not be able to identify the hippocampi properly. And other images also are not that useful. So mainly it is T1 plain or T1 contrast, which is to be used. And preferably FSPGR quality, so that the gray matter and white matter differentiation is very much enhanced. And then next thing is the slice thickness, which has to be optimal around 1.25 millimeter with minimum slice gap, if possible nil or 1 millimeter. And then CT scan also should be in the similar width, so that when you fuse it, it is accurately represented on the CT where the actual planning is going to take place. And you have to fuse both CT and MRI to be able to do it. So just jumping back to the contouring itself. So what you see here will be the contours in the red, and which will be denoting the hippocampus basically. And you begin from where your lateral ventricle's temporal pole horn of the lateral ventricle begins. So that's the first slice where you start contouring, and you look towards the medial part of the edge of the temporal horn. Now, if you look at this temporal horn, you can imagine it is a triangular kind of a thing, right? So your anterior extent is going to be parallel to that anterior extent of the lateral ventricle and temporal horn. And what goes Laterally is what the gray matter is, just around that area. So basically hippocampus is limited to just that volume. So if you look to the next slice, again, this is what you have to end there. So this side, you have just started seeing the lateral ventricular temporal horn, and if you see the anterior extent is limited to the anterior part of that. So you may get confused with the gray matter extending anteriorly, but that's amygdala and you don't take that into the consideration. So it has to stop right over here. It is absolutely in line with your anterior most part of the lateral ventricles temporal horn. So late in upper slices, what you will find is little transfer finger-like projections, going even more medially from the gray matter that you have decoded, and that are called as fimbria, and that they have to be also excluded. So you will have some transition gray, white matter zone between the hippocampus and the rest of the temporal lobe gray matter. So in between, there's white matter line that you have to identify to have this medial border of your temporal lobe. Posterior border is quite clear, so I'm not getting into that. So this is the way you go upwards, and as you go up, you will be able to identify much more clearly the amygdala and the uncus. So again, just to iterate what I said, the anterior part or the boundary between amygdala and hippocampus is identified by the anteriormost extent of the temporal pole of the lateral temporal horn of the lateral ventricle, and uncus is from the fimbria. It will start and it goes towards anterior part of the amygdala. You don't need to delineate those. You have to just be careful where your medial end. So it's basically where the white matter junction with the temporal lobe gray matter, and anterior part is at the anterior part of the temporal horn of the lateral ventricle. So I think if these two boundaries are clear to you, rest all is very obvious. Rest all is a gray white matter zone which surrounds the hippocampi from the other directions. So you just go drawing that upwards, and then you have the uncus recess. So the temporal horn will come anteriorly in front of the hippocampi to make the boundary even much more clearer from the amygdala. And then it goes up, and then you have the quadrigeminal cistern. So you don't go and cover that completely. It's just because you don't want to overestimate the volume or prevent it contouring and unnecessarily forcing your planning system to or be overcharged for not being able to optimize it properly. So you just go upwards, and where again you will face difficulty now is what is the change in the direction. So earlier you were going till that, but now you again see some white matter coming in between the lateral ventricle and your hippocampi. So you have to just restrict it, the gray matter which is surrounding the medial side of the temporal horn of the lateral ventricle. And this is very clear that you just go till here. Now again, one more thing, there are small fimbria here which are going towards the quadrigeminal cistern. So you don't take those also again. So you have to be just limited to that round spot of the gray matter tissue when you are contouring. What you can identify in this slice is basically the parts of the basal ganglia, internal capsule, and you have to it's just to identify the anatomy, but otherwise your hippocampi is quite straightforward in these slices. So major issue what people generally face is basically in the beginning where to start. So starting point is where your lateral ventricle starts. The temporal horn of the lateral ventricle will start. Anterior border is at the anterior edge, along the temporal horn's anterior edge, and then where you have amygdala. So you're not going to take whole of this gray tissue. You have to restrict till the anterior border, and then you don't go into the fimbria. You know that white matter is there, so you just change the contrast of the window. You can identify the fimbria, and uncus can be separated. So that is where you need to be careful. And then all these gray matter again can be confusing, but you have to realize that you have to be there only till the anterior border of the temporal horn of the lateral ventricle. So going upwards, again, there can be some confusion where to end. So, so as the gray signal is no longer visible, so what you see here, this is no longer visible in the next slide. and this is where you stop. Now, what is the tip and the trick? Trick is basically to see in the SAG section. So if you see in the sagittal section of your scan, this will look like a horse shape, and this is what you need to be sure that this is hippocampus, the red contour over here. So if I just scroll it, it is exactly the way it will look in your MR. And what you see over here, this is your ventricular lining, and in front of it, what is coming is amygdala. So if you have taken it by mistake, you will be able to identify it properly in your MR's sagittal section. So this is where we review whenever we are reviewing our scans or the contours of our students also. And even if you are first time contouring, it's best to start from the sagittal thing. So once you know, just go to the thickest where it's clearest, you have the best able to identify the hippocampi region, which is probably this slice, and you just draw the thing over here as a boundary, and then you go to axial. It's very clear where you need to restrict yourself. So this way it is very easy to finish the contour. And once you are there, then you just see it in the coronal also, where it looks like an eye. And again, what you would get confused even here is this part. So this is superior medial part, which is again your amygdala and uncus, and the one which is closer to the ventricle is basically the hippocampi. So it's like something like a C covering it around, on inverse C over this side. So this is where you need to identify that this was not hippocampus if you had contoured that, or you were confused while you were seeing axial contours. Now, just to emphasize what is the green line, which is basically PRV, and the margin to PRV is different in various studies. Somewhere it is 3, somewhere it is 5, somewhere it is 7. So basically it is a PTV kind of a margin, what you employ for your tumor based on your your own institutional setup errors. Same margin you should ideally apply as a PRV margin for setup errors in your hippocampus when you're sparing it, right? And the next thing is what impact it would have on IQ. So you don't have directly much of a dose correlationship which can say that probably this dose and nothing above that is useful. But what I can suggest you is, this is some formula based on the temporal lobe doses which is available. And even if you use the same formula, you see that even at in high risk patients, if you try to preserve the boost doses to hippocampus, or you try to spare them, you have a meaningful difference that you would derive in what would happen to their IQ at the later stage, as compared to giving the full dose of when you would give it by parallel pair thing. So, and the next is, if you do IMRT or proton based RT for medulloblastoma patients, the impact would increase on the IQ sparing because of improved hippocampi dose, because the distance is again a function of what dose you are able to achieve to the hippocampi, and that usually the dose which is most important is said to be the median dose. So I think that's very brief, and I think we are okay with this much, I suppose. Thank you very much, and I am happy to take any questions.
Well, thank you, Dr. Rahul, for highlighting about how to contour the hippocampus very diligently while doing radiation. As we all know, that hippocampal sparing is very important, and actually it poses a lot of challenges, as we know, because delineation is very, very difficult, as you had just highlighted, as well as its central location. So it's very difficult when we are actually contouring to see and define where the hippocampus is. But with your tips that you have come up with, I hope the students as such have been benefited a lot. And we all know that the hippocampus is very, very important to spare, to reduce the neurocognitive decline per se. Would you like to answer how much the dose can be, reduced by sparing the hippocampus? Area?
Yeah, so the textbook varies depending on the situation. Now, if you look at the RTOG study for the whole brain RT, now they say that 5 or 7 gray is more like detrimental, or causing a significant neurocognitive decline versus, or is much better than 30 gray what they would have given without sparing in a whole brain radiotherapy. Now, we all treat brain tumors as a pediatric medulloblastoma, and high-risk patients would get CSI of 36 gray, right? Universally, they would be getting that. Or the adult, even average risk medulloblastoma would be given radiotherapy alone, where it would be 36 gray. But we don't see them being, morons after 5 or 10 years. It is not, so they do get even boost dose, and I don't think majority of us even care to spare the, hippocampus. We might have tried, but I don't think that's also very recent, because we have just recently moved to the tumor bed boost in those medulloblastoma patients. And it's already known that medulloblastoma patients, even if they don't get radiotherapy and somehow they live, pediatric, especially the younger than 3 years of age, they do have severe neurocognitive decline despite being off no radiotherapy, because they have shunts or they have posterior fossa tumor, prolonged hydrocephalus, and neurosurgery. And chemotherapy also may have some indirect effects on neurocognition. So neurocognitive function is a quite complex thing, and it's a very difficult parameter to arrive at a singular dose, and that's why we see such a heterogeneity in literature. So I think the best answer which I can, if I give you in one single sentence, is as low as possible, right? In the context, without sparing the tumor. You should not spare the tumor to spare the hippocampus for sure, right? But if you can, then you bring it to as low as possible. And in my experience, what we have seen, that if you have 1 centimeter distance from your PTV edge from the hippocampi, that's the least distance. If the least distance is 1 centimeter or more, you can at least have 50 to 60% dose reduction to mean dose of hippocampus from your prescription dose, using good IMRT plan. I hope I'm clear. So if you're supposed prescribing 54 gray or 59 gray to your PTV, and the minimum distance, the least distance for the hippocampus to the PTV edge is 1 centimeter or more, you can at least come to 50 to 40% of that prescription dose to the mean of the hippocampus. So it will be around 25 or 24 gray, what you will be able to achieve if you push your physicist hard enough to achieve that. So that's the basic crux. Because you are going to prescribe various doses to the various brain tumors. And if I say 1 dose limit, then it should not be that, if I'm able to achieve only 36 gray, I should not do that. You know what I mean to say? So the whole summary is that, so as low as possible, irrespective of age, if we try hard enough, we can, and probably that may improve their neurocognitive decline rates as compared to other patients.
So when would you not like to spare the hippocampus?
If it is in the PTV, so why would I? So hippocampus cannot be at the cost of life.
Not at the cost of the tumor, of course. So have you seen different variations in the IMRT techniques versus the VMAT techniques? Which one is better to spare the hippocampus per se?
We actually have now moved on completely to rapid arc or VMAT, whatever you say, rotational IMRTs. So we don't do any longer the step and shoot or fixed beam IMRTs, fixed field IMRTs now. But I don't think after 12 fields or 9 fields it matters anyway. So it's more simplicity now with the rapid arc and VMAT, that delivery is within 2 minutes. So otherwise, if you put too many more beams in IMRT field also, you would be able to achieve similar results, I guess.
So what about your take on Mentin as well as hippocampus sparing both together? Have you any experience?
No, I don't have any experience, but I don't think literature is very promising either. So I don't want to. If literature would have been promising, I would have jumped for it. But it has not really pushed it harder. It's like amifostin now, probably going to be going out.
Sure. I truly agree with you on this aspect. Thank you so much for a very, very lucid talk on hippocampus sparing. I do hope that everybody has benefited a lot from your tips and tricks. Thank you so much.
Good night.
Good night.
Thank you, Dr. Pritanjali and Dr. Rahul, for a wonderful radiation oncology session on hippocampal contouring. So with this, we come to the end of day one of this Paras Cancer Conclave 2021. And we'll be joining you tomorrow at 5:30 p.m. for day two. So I hope all the delegates, they liked the session and whatever sessions we put together. And at the end, I would like to thank all the chairpersons, the experts, speakers, delegates who have joined us today. Thank you very much and join us tomorrow.
you.